Uh, Dr. Radhika, are you there? Dr. Aparna, are you there?
Yes, I'm there.
Yeah, yeah.
Am I audible?
Yeah, you are audible and visible as well, Dr. Aparna.
Yeah.
Thanks for joining. Yeah, our moderator is joining, Dr. Radhika. She's supposed to join from Hyderabad, but somehow there is technical issue. So before without wasting time, let me introduce Dr. Aparna, and then next sessions would be taken by Dr. Radhika. So before we'll start, welcome to all our delegates, all IOCCONians who are with us and who have enlightened themselves yesterday. We have 6 sessions yesterday, and it was very fruitful. We have spoken about tobacco cessations, and there is one speaker joined from Iowa, USA. She has spoken about the periodontal disease and what how it leads to oral cancer and all. So today we have a privilege that we are very senior academician, very known oral pathologist with us. Dr. Aparna Dave is a professor and head of the Department of Oral Pathology with 23 years of experience in teaching and research. A graduate and postgraduate of the prestigious Government Dental College and Hospital Nagpur. She specializes in potentially malignant disorders. Dr. Dave has contributed to several national and international publications and has guided numerous research projects. She is actively involved in academic activities and regularly participates in national and international conferences. She is deeply committed to the professional development of both faculty and students, fostering a culture of academic excellence, innovations, and ethical practice. She actively encourages interdisciplinary research collaborations across departments and institutes and strives to integrate contemporary advancement into teaching research and clinical practice. She is always with IOCON in our previous edition, and she is very known academicians who are regular with our program with MedSkill and National Health Academy. So, Dr. Aparna, if I have missed anything, I don't know. I have the updated profile of yours. You guys are doing research regularly, doing publications and all, getting awards, etc. So, I have missed anything you can add on. And over to you. You can start your session. I had made you a co-host, so you can share your slide and you can continue.
Okay, thank you, Dr. Nurul. I'll just share my PPT. Let me know if it is visible.
Yeah, it's visible.
It's visible. Okay.
Just presentation mode, if you can do.
Is it okay?
No, yet it's not in a yeah. No, it's in a presentation mode. Yeah, over to you. You are audible. Your slides are visible in presentation mode. You can continue,
Okay.
Dr. Aparna.
Okay. So, good afternoon, all. Today, I'll be discussing on one of the most challenging yet defining responsibilities in oncology, communicating a cancer diagnosis. Now, this moment is not merely diagnostic disclosure, it is a point where clinical science meets ethic and human emotion. Now, receiving a cancer diagnosis is a life altering event for any patient. Breaking such news is not a single conversation. It marks the beginning of a therapeutic relationship built on trust, empathy, and guidance. For clinicians, it might be one of the many diagnoses that they have delivered during their career. However, for the patient, it is the most significant conversation of their life. In oral oncology, often the dentist is the first healthcare professional to suspect or diagnose the condition. For many patients, this comes unexpectedly, often during a regular dental visit. The word cancer carries a profound emotional weight, commonly associated with fear, uncertainty, and distress, making sensitive and compassionate communication essential. Revealing a cancer diagnosis has evolved significantly over time. With non-disclosure, which was common until late 20th century, in modern practice, honest and compassionate communication is taking over. Today, the challenge is not whether to disclose, but how to do it effectively. Complexities of oncology, disclosure remains underexplored. Thoughtful, empathetic, and patient centered communication is therefore essential in cancer care. Patients may forget our words, but they never forget how we have told them that they have cancer. How we communicate at this moment shapes trust, treatment decisions, coping behavior, and lays the foundation for a long term doctor patient relationship. While specific medical details may fade over time, patients may forget staging or medical terminologies, but rarely forget how they were made to feel. Patients constantly retain memories in form of the tone of the voice of doctor, the presence or absence of empathy, the clarity or confusion of the conversation. In oral cancer, particularly, where the patient already faces a stigma related to tobacco or alcohol use, insensitive disclosure may increase guilt, denial, or may even contribute to delayed acceptance or treatment refusal. Compassionate communication, therefore, is not merely a soft skill, it is a clinical responsibility that directly influences the outcome. In the past, doctors made decisions for patients and often chose whether or not to tell them the diagnosis, believing they knew what was best for the patient. Non-disclosure or family-first disclosure was common practice, particularly in many Asian and lower resource settings. Physicians often informed relatives before the patient, based on the assumption that full disclosure might cause psychological harm or diminish hope. However, over the past few decades, there has been a significant shift in the oncology communication. The focus has moved towards recognition of patients' right, particularly the right to know one's diagnosis. The principle of informed consent has become central to ethical medical practice, requiring transparent discussion of diagnosis, prognosis, and treatment choices. Respect for patient autonomy now mandates that individuals be active participants in decision making regarding their own care. Modern oncology no longer supports concealment as a routine practice. Instead, the emphasis is on structured, honest disclosure delivered with empathy. The contemporary approach can be summarized as truth with compassion, where factual accuracy is balanced with emotional sensitivity, cultural awareness, and psychological support. Thus, the evolution of cancer communication reflects a broader transition from paternalism to patient care center. Now, why oncology or why communication matters in oncology? Effective disclosure improves treatment acceptance by enhancing patient understanding and promoting informed decision making. When patients perceive clarity and empathy, they are more likely to adhere to recommended therapies. Communication also significantly affects psychological well being. Structured, compassionate disclosure can reduce anxiety, uncertainty, and support adaptive coping during the vulnerable period. In contrast, inadequate or insensitive communication may provoke fear, denial, anger, or emotional withdrawal. Such responses can lead to treatment refusal, poor compliance, and delayed decision, and reduce satisfaction with care. Suboptimal disclosure also increases the risk of mistrust and potential medico legal consequences. Thus, communication in oncology is not ancillary. It is the core clinical competency that shapes both therapeutic and psychosocial outcomes. Effective cancer care begins not with chemotherapy or surgery, but with communication, honest, ethical, and compassionate. Now, a cancer diagnosis often produces an immediate and profound psychological response. Patients commonly experience shock and disbelief, particularly when symptoms are minimal or unexpected. This is frequently followed by an intense fear of death and disease progression and anticipated suffering, including the concern about pain, disability, and impact on family. Anxiety, depressive symptoms, and denial are also common early reactions. While some degree of distress is normal, but persistent psychological disturbances may impair coping capacity and influence treatment decision. So after the disclosure of cancer diagnosis, patient typically undergoes three psychological phases. The first is an early reaction, occurring within days, often marked by shock and temporary denial. This is followed by a distress phase, which is characterized by anxiety, poor concentration, loss of appetite, and depressive symptoms. Finally, in the adaptation phase, which could be after several weeks to months, the patients gradually begin to accept reality and attempt to adjust to their new life circumstances. Now, studies have been carried out to assess the level of stress or anxiety when the patient has been informed about the diagnosis as compared to those who were unaware of the condition. Such studies have reported that those who knew the diagnosis did suffer from emotional distress or anxiety, which affected their well being and daily functioning and the treatment outcome. However, some of the patients who were unaware of the diagnosis, they can also suffer from stress because they are uncertain about their treatment and their disease. Therefore, recognizing and addressing emotional responsibility is a critical component of comprehensive oncology care. Patient may forget the medical details that we explain, but they will not forget how we made them feel when they were first informed about the diagnosis. Now, as far as families are concerned, a cancer diagnosis does not affect the patient alone. It profoundly impacts the family unit. Family members often experience significant emotional distress, grief, and anxiety regarding prognosis, finances, and caregiving responsibilities. This distress may manifest as overprotective behavior, including attempts to shield the patient from full diagnosis, a phenomena which is commonly observed. Additionally, families frequently carry a substantial decision-making burden, particularly in advanced diseases, where choices regarding surgery, chemotherapy, or palliative care must be made under emotional strain. Therefore, effective oncology communication must address not only the patient's needs, but also the psychologically and informational need of the patient. Who should be informed first? Given the significant psychological impact on both patient and their families, an important practical and ethical question arises. Who should be informed first and how should the disclosure be structured? Should the information be directed primarily to the patient or to the family members or jointly? Now, this is based on individual preference or cultural contacts. Determining who should be informed first and how disclosure should proceed is the key ethical decision in oncology practice, requiring a careful consideration of patient's autonomy, family dynamics, and personal preferences. In many clinical situations, it is the family members who often assume a central role in the clinical disclosure. In many instances, particularly in India, families do not wish to disclose so as to avoid too many questions asked by friends and relatives, or at times to avoid negative suggestions made by relatives and friends. Sometimes They also wish to prevent unnecessary courtesy visits and the social attention that may add to the patient's and family's emotional burden. Family members may act as primary decision maker, influence treatment choices, and at times attempt to control the flow of information that needs to be shared with the patient. Beyond decision making, families also serve as critical sources of emotional, financial, and practical support throughout the cancer journey. Therefore, effective oncology communication must acknowledge the vital role of family members in communication diagnosis. Beyond the emotional and ethical dimensions, there are essential clinical realities that must be clearly communicated at the time of diagnosis. First, the diagnosis itself, including histopathological confirmation, must be explained using a simple, clear language instead of a complicated medical terms that which the patient might not understand. For example, instead of saying that the patient has a moderately differentiated carcinoma or a squamous cell carcinoma, what could be done is the patient could be told that you have a type of cancer of your lining mucosa, and eventually he can be explained at a later date. Secondly, the stage and prognosis should be discussed with honesty while acknowledging inherent uncertainties. Patients should understand the extent of disease and the implications of the outcome. Third, the treatment options, including surgery, radiotherapy, chemotherapy, or combined modalities, must be outlined with risk, benefits, and alternatives to facilitate informed decision making. In head and neck oncology, it is important to address potential complications that could be faced, such as impairment of speech, mastication, swallowing, and possible facial disfigurement, as these significantly affect the quality of life. Finally, the survival statistics, when discussed, should be informed very carefully, emphasizing variability and individual factors rather than presenting absolute figures. Avoid information overload. Too much of information will not serve any purpose. Rather than absolute statements, it's better to discuss the prognosis in ranges, emphasize treatment possibilities, and reassure continued support regardless of outcome. After explaining the diagnosis and treatment option, patients often ask the most difficult question regarding maybe about survival or regarding coping up with the treatment. In oncology, prognosis is never exact. Outcome depends basically on multiple factors, and no doctor can predict with complete certainty. Therefore, we must balance hope with realism. Giving false reassurance is harmful, but being over blunt can destroy morale. It is better to discuss prognosis in terms of chances or ranges rather than define statement. We should acknowledge uncertainty while emphasizing that treatment option exists and each patient's journey is unique. The approach to uncertainty is grounded in four core principles of biomedical ethics. Autonomy affirms the patient's right to know their diagnosis and to participate in decisions regarding their care. Beneficence requires us to act in patients' best interest, ensuring that information shared supports a meaningful and informed decision making. Maleficence obligates us to avoid harm, including unnecessary psychological distress caused by insensitive communication. Justice demands fair and honest communication for all patients, regardless of their background or circumstances. Truth telling, therefore, is not optional. It is an ethical duty inherent to professional integrity. However, ethical disclosure does not imply blunt or insensitive disclosure. Honesty must be coupled with empathy, timing, cultural sensitivity, and emotional support. The goal is not merely to inform, but to communicate in a manner that preserves dignity and trust. If ethical principles guide why we must disclose truthful and compassionately. And the next question is, how do we do it effectively in a clinical practice? One of the most widely accepted frameworks for breaking the news in oncology is the spikes protocol. Though there are few more protocols which are available, but this one particular protocol is more widely accepted. Spikes protocol provides a structural approach to deliver difficult news in a systemic and empathetic manner. In this, it is important to ensure privacy, involve the clinical family members as per the patient's preference, sit down, make connection and establish rapport with the patient, and manage time constraints and minimize interruption. So it could be an one-to-one discussion with the patients without any interference of maybe the assistants or the sisters or the other patients. Assess what the patient already understands about their condition. This prevents the information overload and corrects misconception. Listen to the patient's level of comprehension. Accept denial but do not confront at this stage. Maybe at a later date, the patient can be convinced about the treatment plan and other things. Ask how much detail the patient wishes to receive, or probably you'll have to judge how much the patient can receive the information. Not all patients desire the same depth of information. Accept patients' right to know. Offer answers to the questions at a later date if the patient wishes. Deliver information clearly and gradually. Avoid using technical words. Some warning information can be given to the patient so as to prepare the patient emotionally to receive the news. Considering the educational level, the socio-cultural background, current emotional state, give informations in small bits, small chunks. Check whether the patient has understood what you have said. Respond to the patient's reaction as they are occurring. Give any positive aspect first, that it has not spread, or probably it is very responsive to the treatment, or there are treatments which are available locally. So that will boost his morale. Give facts accurately about the treatment option and prognosis, and if possible, about the costs. Recognize and respond to the emotional reactions with empathy. Allow silence and validate the feelings. Give patient time to express his or her feelings and then respond. Conclude by the outline the next step, reinforce support and ensure understanding. Inquire whether they want to clarify something else. Spikes transform disclosure from an unexpected finding into a guided therapeutic conversation. There is a tussle between truth telling and therapeutic privilege. Truth telling is fundamental ethical duty in healthcare. It involves honesty, informing about the patient, about the diagnosis, severity, treatment option, and prognosis. It respects patients' autonomy and supports informed decision making. Therapeutic privilege, on the other hand, allows doctor to temporarily withhold specific information if immediate disclosure is likely to cause serious psychological harm. Not just sadness, but significant mental distress or breakdown. Importantly, this should be used cautiously and only in exceptional situations. In India, we often encounter families requesting not to disclose, saying that the patient should not be informed or patient will not be able to take or manage it. This reflects the cultural collectivism where the family plays a central decision making role along with a protective attitude and fear of emotional harm. However, ethically and legally, if the patient is competent, they remain the primary decision maker. Our responsibility is to balance cultural sensitivity with respect to patient autonomy. Cultural difference between India and Western countries significantly influence medical communication, especially in serious illness like cancer. In Indian context, the Indian context reflects a more relational and family integrated model of care. Decision making is often shared. Major health decisions are often taken collectively. Families may seek involvement in timing and manner of disclosure, with an emphasis on emotional safeguarding and socio-economic realities such as financial constraints. In Western countries, healthcare systems are largely based on individualism, where patient autonomy is central ethical principle. Patients are usually informed directly about their diagnosis. Doctors are expected to tell patients the full truth about their diagnosis clearly and directly because the law and medical ethics require that the patients have the right to know and make their own decisions. Patients are generally regarded as the primary decision maker and are expected to participate independently in treatment choices. While the Western country practice focuses on direct truth telling and legal informed consent, the Indian context often balances patient rights with family involvement and cultural sensitivity. What we need to understand is that there is a limited formal training in communication skills in our undergraduate dental curriculum. Multiple surveys and studies have highlighted the urgent need to equip practitioners with the essential skills and structured protocols that are required for effective and compassionate communication. Whereas in Western educational settings, probably the communication skills are better structured, which significantly enhances both confidence and competence among dental students and practitioners. Effective the common communication pitfalls which we can experience is sometimes if complex medical terminologies are used, or probably the physician or the doctor doesn't have time and gives a disclosure about the diagnosis to the patient, or probably it is done in an area where there is no proper setup, there is no separate area for the patient. In those cases, probably it puts a burden on the patient. So, effective cancer disclosure requires practical communication strategies that translate ethical principles into everyday clinical practice. Clinicians should ensure a private, uninterrupted setting, sit at eye level, maintain appropriate eye contact to build a rapport. Information should be delivered in clear, simple language in small segments and checking patients' understanding. Giving hints before disclosing serious information. Can we just unmute the person, one speaker? Dr. Noor? So, allowing silence, acknowledging emotion, responding with empathy are essential to maintain trust. Finally, the discussion should conclude with a clear summary of next steps, reassurance of continued support, and an opportunity for questions, ensuring that the patient does not leave the consultation feeling isolated or confused. Be patient, give some time to the patient to think. So, to conclude, I would like to say communication in oncology is not merely an interpersonal skill. It is a clinical competency that directly influences patient outcome. Truth must be conveyed with compassion, guided by ethic principles such as autonomy and beneficence. Emotional response are not secondary. They shape adherence, coping, and trust. Finally, structured frameworks like spikes provide practical guidance to ensure that difficult conversations are conducted with clarity and sensitivity and professionalism. Let us strive to treat not only the tumor, but the person who hears the diagnosis. Thank you.
Thank you very much, Dr. Aparna ma'am. That was very clear and insightful presentation on how to communicate the cancer diagnosis. Very thank you, ma'am.
These are some references. So thank you.
Thank you, ma'am.
Okay.
If you have any doubts or questions, please feel free to ask or type in the chat box.
Okay, thank you.
No questions right now, ma'am. Thank you so much. So, with those valuable insights fresh in mind, let us now proceed to our next session. It is a privilege to spotlight one of the most respected figures in oral pathology, Professor W.M. Tilakaratne. Professor Tilakaratne currently serves as a professor of oral pathology and senior consultant in the Department of Oral and Maxillofacial Clinical Sciences and as Associate Dean, Faculty of Dentistry, University of Malaya. Over the past 3.5 decades, he has held distinguished academic positions worldwide, including Professor of Oral Pathology at Queen Mary University of London and visiting professorships at leading universities in Australia, New Zealand, Thailand, India, Malaysia, and the UK. He is also the former Dean of the Faculty of Dental Sciences, University of Peradeniya, Sri Lanka, and a past President of the International Association of Oral Pathologists. His research contributions are globally recognized. He is listed among the top 2% of scientists worldwide by Stanford University and was the first practicing scientist in Sri Lanka to achieve this distinction. He has received the VD Award for Best Researcher in Medical, Dental, and Veterinary Sciences in Sri Lanka, along with multiple presidential research awards. His primary research focus lies in oral cancer and potentially malignant disorders, areas where his work has had a transformative impact. Professor Tilakaratne has published more than 185 scientific papers, holds an H index of 47, authored 2 internationally acclaimed textbooks, and contributed to 44 chapters in leading reference works. He also serves as an editor for the latest WHO classification of head and neck tumors and the IARC handbook on oral cancer prevention. In recognition of his pioneering contributions, he became the first dental surgeon elected as a Fellow of the National Academy of Sciences, Sri Lanka. With such an illustrious career and global influence, it is an honor to welcome to this conference a scholar, leader, and authority on oral pathology, Professor W.M. Tilakaratne. Sir, the stage is yours.
Thank you. Am I audible?
Yes, sir, you're audible, sir. You can continue with the presentations.
Okay, let me share the screen.
I request everyone to mute yourself before the presentation starts.
Can you see the screen?
Yes, sir, it is visible, but can you go to the presentation mode, sir?
Yeah.
Yes, sir.
Yes, sir. See.
Yes, sir. It is visible.
All right. Okay. So first of all, let me thank the organizers for inviting me to give this lecture. What I'm going to talk to you today is some aspects of the role of pathology in the management of oral cancer. Now, before going into details, I want to highlight some of the key facts about oral cancer. As we all know, the early diagnosis is the key to better prognosis, not only for cancer, for any disease. And when it comes to cancer, TNM stage is very important and critical in drawing the treatment plan for a given cancer. And most pathological aspects of a given cancer is a predictor of prognosis. And more importantly, pathology of a given cancer given in the histopathology report should be used to draw treatment plan together with, of course, other clinical parameters. What is the pathologist's role? There are many aspects. It is not only just telling the clinician that, yes, your patient has got a squamous cell carcinoma, but the role of the pathologist goes much beyond that. So, in short, pathologist is responsible to give the definitive diagnosis and to mention about histopathological parameters which have some impact on treatment planning and prognostic prediction, and molecular markers, if there are any, in order to use as adjunct treatment, targeted therapies, or the markers which can predict the prognosis. And then the pathologist should play a pivotal role in the multidisciplinary team meeting, where the surgeon, the pathologist, the radiologist, speech therapist, the prosthodontist, and all others should take part in the MDT, and pathologists should play a significant role in that. And more importantly, what surgeons expect from the pathologist is the status of the excision margins. Yes, it is a histopathological parameter, but that's a very important one for surgeons. And the nodal status, similar to excision margin, that is something that is very important in order to decide the further treatment. And of course, the pathological TNM staging is the ultimate thing that decides the stage of the cancer. And another, the significant role that pathologists should play in terms of management of oral cancer is the related research in oral cancer. Well, when it comes to diagnosis, I don't need to tell you the fact that large majority of cancers are diagnosed, almost all squamous cell carcinoma, especially in South Asia, diagnosed with the use of incisional biopsy. And cytology is used in some countries like Japan, but cytology, of course, has its own drawbacks in terms of giving the histopathological parameters which are important to plan the treatment. So those things will not be there in cytology, and false negatives and positives are also possible. I will show you some research. And if it is the large growth, the fungating mass or very big lesion, we don't need adjunct techniques to decide where to biopsy. But if it is a smaller lesion, the flat lesion, the mucosal, the just red and white lesion, where the clinician is in doubt which part is more malignant, so you can use adjunct techniques like Wellscope, toluidine blue, etc. So these just to show you, because of the time factor, I'm not going to explain these techniques in detail, but this is these are some pictures of toluidine blue, how important it is. Now, these are cancer of the lateral border of the tongue. After toluidine blue, here you can see the dark, the blue staining. And here, now these are the dye retaining areas are the most suspicious areas of malignancy. According to current evidence, the toluidine blue is good in detecting carcinoma, but its sensitivity in detecting dysplasia is not that great. High percentage of false positive stains, that is why it says the sensitivity is not great. And also the subjectivity interpretation of the color. So those are drawbacks. Otherwise, toluidine blue is in the low income setting is a fairly effective method to decide where to biopsy. Now, the Cochrane review says that none of the adjunctive techniques can be recommended as a replacement for the currently used scalpel biopsy and histological assessment. As a pathology, that is what I also believe when it comes to oral cancer. So the incision biopsy is always the best. Now, this is a piece of research that we used to see how effective cytological techniques, especially the spatula technique over cytobrush, but both are effective, but you can see the cytobrush is more effective than spatula for the diagnosis of both cancers, or malignant lesions, as well as OPMDs. With the cytobrush, it is around 90 or more than 90%. So that is good enough sensitivity. Now, when selecting a biopsy in a small lesion, as I told you, it's not a big problem. If it is a large flat lesion where the cancerous area is doubtful, then you have to use the adjunct techniques, or there is no harm doing multiple biopsies in a large lesion if you are not sure which part has definite invasion. Now, this is very important, the correct size of a biopsy. The length of the biopsy should be 1 centimeter, and the depth of the biopsy should be about the 0.5, and width should be 0.6. So if you have a biopsy of that nature, the pathologist cannot say biopsy is inadequate. So that's very important. But although I say this, not all sites of the oral cavity you can go for these measurements, especially small gingival carcinoma, you can't take these large biopsies. But when it is buccal mucosa, floor of the mouth, the tongue, etc., so you should always follow the guidelines. Unless you do that, it's exceptionally difficult for the pathologist to give all the histopathological parameters. As you can see, the advance in front of the cancer, that is where most of the prognostically important parameters are there. The pattern of invasion, the host response, and various things. And if you want to measure the depth of invasion, now including this invasive front is exceptionally important. Now, these are some examples of the biopsies which are not suitable to be sent to the pathologist. Now you can see this is the whole biopsy, and more than 2/3 of the biopsy is the normal mucosa. Now this is the normal mucosa, and this is the only cancerous part. It is even less than 1/3. So it should be the other way around. So therefore, always it is good to include some normal tissue, especially in dysplastic lesions, for the pathologist to compare normal. When it comes to mild dysplasia, it is exceptionally important, knowing the fact that dysplasia grading is very subjective. Now, this is a basic principle that should be practiced, good for postgraduates who are listening to this. And also, when you have this kind of large lesions, exophytic lesions, now don't do a biopsy from the top. Just plucking the top is not going to give you a definitive diagnosis. Even we struggle to decide, although despite the fact that clinician says it's a large T4 lesion, but when we look under the microscope, if you get this kind of a biopsy, let me get the pointer. If you get this kind of a biopsy, you cannot see the definite evidence of invasion, because without seeing invasion, pathologists will not tell you that it is cancer. So if you include this correct depth dimension that I mentioned, and we see the full thickness of the cancer, where we can assess all different parameters, pathological parameters, which are important: the level of differentiation, the host response, invasive front, what kind of tumor is at the invasive front, is it discohesive or cohesive tumor? All that can be assessed if we have a biopsy, inadequate biopsy of correct dimensions. And sometimes it is not easy for us to decide what the cancer is. Now, if you look at those who are in the audience who are familiar with pathology, now when we have the biopsy like this, we don't know what it is. It's a large cell, very nasty malignancy, right? It could be poorly differentiated carcinoma, lymphoma, melanoma, or even undifferentiated sarcoma. So therefore, always, whenever you have a diagnosis of undifferentiated or poorly differentiated carcinoma, always think, if you have a doubt by looking at other clinical pathological parameters, if you have a doubt, always discuss with your pathologist. Now, this case, now where we did immunohistochemistry because we could not decide what the lineage of the cells are, and this is cytokeratin. This brown stain means it is positive. Cytokeratin is positive very strongly. That tells us the epithelial malignancy coming from the oral mucosa. So we know it is a poorly differentiated squamous cell carcinoma. That information is exceptionally important because the treatment of lymphoma, melanoma, sarcoma from carcinoma are very different. Sorry, my slide is not moving. Right. Okay, now just to show you how important immunohistochemistry is. Now, this is a 56-year-old female patient presenting with a large polypoid mass on the tongue in the posterior 1/3. And this is what we saw. We can see the surface epithelium is dysplastic and the tumor islands going into underlying tissue. That is invasion, so we know it is malignant. But when we look at it, in addition to these epithelial-looking islands, we have another component to the tumor. We don't know what it is. Right here, it is not like squamous cell carcinoma, more spindly or the slightly oval-shaped cells. And when we stain it, you can see this brown staining is positive. Now the epithelial-looking islands are negative for this particular immunohistochemistry. Now this we went in for mesenchymal marker, right? So it is, we know this, the other compartment of this cancer is mesenchymal in origin, and this is epithelial origin. If you do a cytokeratin, now this again the mesenchymal stain in the mesenchymal part. So this is cytokeratin. As I showed you, you see the epithelial islands are coming up very nicely in brown color. So that is positive. So we have the epithelial component as well as the mesenchymal component. That is carcinoma plus sarcoma. So we know it is a carcinosarcoma. So it shows you how important immunohistochemistry, although it doesn't play a very big role in squamous cell carcinoma, but rare examples, they do play a role in immunohistochemistry. Now, what are the histopathological parameters that are important? We look when we have a biopsy of adequate size, as I mentioned earlier, whether these parameters are present. Pattern of invasion, that means the advance in front of the tumor, whether it is cohesive or discohesive. There are various grading systems, pattern 1 to 4, 1 to 3, 1 to 5, etc. So whatever it is, the most important thing is whether the cells are cohesive or discohesive. Then the immune response, the depth of invasion, vascular or perineural invasion, the level of differentiation, HPV status, very important. We know there are not many cases of oral cavity HPV positive, but minority, especially the posterior part of the mouth. And the margin status, I mentioned that earlier, and the nodal status, and whether there is extranodal extension. Now, all these parameters are exceptionally important in order to plan the treatment, whether it is the primary treatment or the adjunct treatment. Now, in the TNM classification, the 8th edition, they included some histopathological parameters to grade. One of them is depth of invasion. Now, in the past, we know the before 8th edition, this up to 7th edition, T1 tumors are tumors which are less than 2 centimeters in diameter. But for the 8th edition, that is there. But in addition to that, if the lesion is although smaller than 2 centimeters in diameter, but the depth of invasion is more than 5 millimeters, we upgrade it to T2. Similarly, we do the same thing for T2 tumors, which have a higher depth of invasion. So that, with a lot of research, have shown clinically very, very relevant. So this is the depth of invasion. Depth of invasion we usually measure from the basement membrane of the normal area up to the deepest point of the cancer. Some people measure it from the top to bottom, that is the tumor thickness, which is not a very accurate marker compared to depth of invasion. Depth of invasion is very important in order to decide elective neck dissection. Now, in the past, the cutoff point was 4 millimeters. If it is more than 4 millimeters, despite the fact that the neck is clinically negative, and most surgeons go for elective neck dissection. Of course, there are other features which are also taken into account. So pattern of invasion, this one, the way of doing it is according to Royal College of Pathologists of the UK. And there are 4 types. The type 1 is the cohesive, like in verrucous carcinoma. Type 2 is large, the islands of tumor. And type 3 is small strands of tumor, which are less than 15 cells in thickness. And type 4 is the presence of individual tumor cells at the advancing front. Now, type 1 and 2 go as cohesive and invasive front, and type 3 and type 4 go as discohesive. Now you can imagine, now these type 3 and type 4 can easily find a blood vessel or a lymphatic in order to go into lymph nodes. And also you can realize now when this pattern of invasion is type 3-4, the stroma is myxoid looking, and this lymphoid infiltrate is not there in most cases. That again enhances these tumor cells to find the lymphatic or blood vessel much easily. So this is the worst pattern of invasion. It has 5 types. Now this is the 5th type. Now this is the main tumor. You get tumor islands about 1 millimeter away from the main tumor mass. So that tells us that tumor has a very poor prognosis. Now this vascular invasion, this lymphatic actually, so you see the ball of tumor is inside the lymphatic. There is no 100% guarantee, although this is there inside the lymphatic or a blood vessel, it's going to end up in a lymph node because it has to fight with the body's host mechanisms inside the circulation also, but most of them end up in a lymph node. Now this perineural invasion, so these are the nerve. Ideally speaking, more than 1/3 of the nerve should be covered with tumor to say it is perineural invasion. But here in this case, you can see almost 100% of the nerve is covered with tumor. Post-immune response, now we say light, moderate, and dense. Now you can see light lymphocytic host response, very little lymphocytes, and the tumor cells can move freely in the connective tissue. But dense, when you look at this, now all these blue dots are the lymphocytes, and these are the tumor islands. Now these tumor islands cannot move anywhere. Well, that is why when a tumor has good host immune response, the metastatic rate is much less and the prognosis is much better. And this is another thing that we as pathologists tell the clinician, simply because not they are morphologically different, but they are prognostically different, right? Although we say squamous cell carcinoma, it has many different histopathological subtypes. So some of them have a different behavior. Conventional squamous cell carcinoma is the one we label as well-differentiated, moderate, and poor. Large majority, about more than 90% of squamous cell carcinomas belong to that category. Verrucous carcinoma, although we call it carcinoma, there is no hallmark of cancer there, that is invasion. And basaloid squamous cell carcinoma has a poor prognosis. It has the worst prognosis out of all subtypes. Adenosquamous going very closely to basaloid. Adenoid papillary they more or less behave like conventional squamous cell carcinoma. Now, spindle cell carcinoma is something that you need to understand, especially they occur after the primary squamous cell carcinoma is treated with radiotherapy. So if you get spindle cell sarcoma as the diagnosis for your recurrent tumor, then you have to raise your eyebrows and think, oh, it could be spindle cell squamous cell carcinoma due to radiotherapy, because treatment, your radiology and chemo regimes can be different. And the carcinoma caniculatum is a fairly recently described entity. Again, subtype with better prognosis and metastatic rate is very less. So this level of differentiation, well differentiated, means you can see squamous cells very nicely seen in tumor islands, not difficult to identify. And the normal function of the keratinocytes are intact, that is production of keratin. So when you have more keratin and the cells are looking like squamous cells, it's a well differentiated. Moderate is little difficult to identify them as squamous cells, and keratin production is much less. Poorly differentiated, you see, nobody can say for sure these are squamous cells. So this is the instance where you need immunohistochemistry. So this has a better prognosis, this has a very poor prognosis. Other histopathological subtypes, just for the completion, this conventional, this verrucous, you see there is no invasion, but pushing front, we call this. Now it can push the muscles, so bone can get saucerized, but there is no true invasion as such. So it's, in a way, it's a misnomer. But verrucous carcinomas, remember, with time, start to show invasion, and then they are well differentiated. Squamous cell carcinomas, some people call them as hybrid squamous cell carcinoma. Now, these basaloid adenosquamous, you have adenocarcinoma at the bottom and the squamous cell carcinoma on top. And this spindle cell carcinoma, usually, as I told you, seen in recurrent squamous cell carcinomas after radiotherapy. And this is adenoid, it is glandular looking. Another name for this is acantholytic squamous cell carcinoma. So that is mostly UV light induced squamous cell carcinoma, especially in the skin. So this is one of the studies we did to identify how important these histopathological parameters are. So you can see, beyond doubt, we have shown that the site is very significant. Buccal cancers has a better prognosis compared to tongue cancers. Tongue cancers have higher metastatic rate compared to buccal mucosal cancers. And the pattern of invasion is very significant. Host response, as I showed you, is very significant. And the excision margins, again, significant, and perinatal invasion. Now, in the biopsy pathology report, if you have these features mentioned, then clinicians should take a note of that, because they have definite impact on prognosis. Therefore, they are the parameter that you can plan your treatment little towards radical direction. So these, just to show you some of them, the Kaplan-Meier curves. You can see the pattern of invasion. Type 1, type 2, they are the more cohesive, invasive front, and the type 3 is the discohesive. You see 5-year survival rate is much less compared to the cohesive front squamous cell carcinoma, so pattern 1 or 2. For the further management, these are the two main things that you need to embark on: the nodal status and the excision margins. So they are exceptionally important. Nodal status are important for you to decide radiotherapy or, in rare cases, chemotherapy, and the excision margin status are the key to decide whether you are going for extended excision. So similar to depth of invasion, now 8th edition of AJCC included extranodal extension as a parameter to decide the end stages. Even we used to consider the nodes which are less than 3 centimeters in diameter as N1, But if it shows extranodal the extension, it can be upgraded to N2A. So this is extranodal extension. You see it's going beyond lymph node. Now this is the lymph node. You see that is the capsule, subcapsular sinus, and tumor islands are just going away from the lymph node. So early extranodal extension. Now here we can see the tumor islands are going into paranodal tissue. So it is the responsibility of the surgeon to guide the pathologist on different levels. We know what level of lymph nodes are positive is very important in order to decide special radiotherapy. So therefore, it is the duty of the clinician to label the specimen correctly. We know the level 1, level 2, and level 5 have the A and B, two subgroups as well. So all those things are there for a reason. I don't have time to describe why it is so. So anatomical landmarks are very important to identify these different levels. But remember the fact that when we receive, if it comes in formalin, the specimen is fixed and the pathologist cannot identify 100% correctly what the levels are. But ideal way of sending a specimen is to mount it on a fork board or some kind of a board and to have labels on different areas. Then it is very easy for the clinician and it's very accurate. You don't need to use sophisticated things. Now you can mount like this. Now this is a bilateral neck dissection. The surgeon is very good in marking level 1 to level 5. So this is very important, and your accurate biopsy pathology report will lead to accurate post-op treatment. Excision margin, this is what we consider the more than 5 millimeters here, 1 to 5 close, and less than 1 millimeter involved. This is the Royal College of Pathologists guidelines, and this is what we use. Actually, my advice is for all the cancer surgeries, the oral squamous cell carcinomas, if you have facilities, do frozen sections while you are doing surgery in order to see whether the excision margins are clear. Now, sometimes we receive biopsies like this, excision like this, without any labeling. Then it is exceptionally difficult for us to decide what is the anterior, what is the posterior, what is the superior, and what is the inferior. So that doesn't serve any purpose. That biopsy report, if you say one margin is involved, then surgeon doesn't know where to go back and re-excise. So again, it shows clearly the excision margin from clear to involved. The survival is very different now. This lower line is the involved margin. So compared to the clear margins, prognosis, so survival is much poorer. Presence of dysplasia at excision margins, the subject of debate, but I believe if it is moderate or severe epithelial dysplasia, it is better to consider as positive margins. Mild dysplasia, there is a split of opinions. But most people practice no further treatment if we say the cancer is completely excised, but mild dysplasia extends to the margin. But it has been shown that even the mild dysplasia present at the advancing the excision margin, recurrence-free survival and disease-free survival can be lower compared to clear margins. So therefore, that is why I said it is better to do frozen sections at the time of surgery. So this Kaplan-Meier curves show from negative to severe dysplasia at the excision margins, how overall survival change. So it has a definite direct relationship to the dysplasia level at the excision margin. So as I told you, if there is mild or moderate epithelial dysplasia is present in the mucosal margin, the chance of local recurrence within 5 years after surgical removal of the primary is over 50%. So according to some studies, they consider immediate re-excision if feasible. If it is moderate to severe epithelial dysplasia, there is no doubt you should go back and do the re-excision. Again, it shows when there is no dysplasia to severe dysplasia at the margin, there is definite difference in the local control and also disease-free survival. HPV. Now, HPV is usually in oropharyngeal cancers, the HPV 16 usually. But we see a very minority of oral cancers having HPV positivity. Why? The good news is when it is HPV positive, we know they are chemo radiosensitive, so therefore they have a better prognosis compared to HPV negative cancers. So these are the AJCC-TNM staging. So because of the time factor, I will skip that slide. And I strongly advise you all to use some database for the recording of all your data, pathological data and surgical data in a database. So there are enough databases available. Now, International Collaboration of Cancer Reporting regularly provide this database. This is free of charge. So we did the latest one very recently. So you can go to ICCR website and download these databases as shown here. So then at the end of 1 year or a few years, you have all the data to compile and to come up with some good research papers which are practically important for our part of the world. Now, why research is needed in OPMD and oral cancer? And of course, although I showed you various parameters, how significant they are, now significant number of those papers are not coming from our part of the world. Therefore, to understand the disease in our part of the world, the oral cancer and OPMDs, we need research. And to refine diagnosis, again, research is a must. The improved treatment, improve yourself as a surgeon or as a pathologist. You can improve your skills by doing research and to draw up the common treatment protocols and guidelines. What we use is mostly the treatment protocols drawn up by AJCC or coming from the West. So remember, the cancer that we see, the oral cancer that we see in this part of the world is not the same. So I have lectured on that subject extensively. So therefore, we need to use our material from betel quid induced cancers, mostly OSF background cancers, so and do research to draw up these guidelines. There are a lot of unanswered questions in oral cancer, especially in South Asia. Is oral cancer in South Asia different from the rest of the world? I strongly believe the answer is yes. So therefore, we need research to look at all those histopathological parameters, whether they are same as the cancers coming from the rest of the world. Is biological behavior different? Yes, it is different. We know at least for OSF-induced oral cancers, their prognosis better, and also the metastatic rates are much less. Is there a difference in the molecules driving the disease? This research should come from our part of the world. Is it correct to use treatment protocol from elsewhere? So probably not, because of the fact that the etiologically different cancers in this part of the world. And do we have enough research from this part of the world? Again, a big no, so we should embark on more research. And we have come up with, because of the time factor, I'm not going to describe these things. Now, there are histopathological models to decide the treatment options. We have come up with few models in the past. Few of them are very recent. Looking at some important histopathological and clinical parameters, and for the surgeons to decide, especially if it is clinically negative neck, what kind of neck dissection they should go for. Now we use T-stage, depth of invasion and pattern of invasion, and we have provided this graph showing these red areas are highly likely to end up in lymph nodes, so you have to do elective neck dissection despite the fact that they are clinically negative, and so on. So I have no time to describe the whole graph, but these different colors show how much is the risk. With that, I think my time is over. Thank you very much. I'm more than happy to answer any of your questions.
Thank you, sir. It was a truly enlightening presentation. You may share your queries directly or type them in the chat box. And one of the participants has asked for the mail ID, sir. Could you please share your email ID in the chat box, sir?
Sir, good evening, sir. Very nice and very informative session. We are very much thankful for you. There's one question which I wanted to ask you. like the cytology role, like in what way we should be dependent on it. Like it's not for the cancer also, it's for any oral mucosal alterations. Like doing a cytology and the findings which are we are getting on the cytology, how much we should rely on that, and if not at all, then when to do it exactly, and then if needed, how it has to be performed.
Yeah, good question. The role of cytology I actually mentioned in the lecture, but for most pathologies, it's doubtful. To start with, my recommendation is cytological smears, whether it is FNAC or scraping,
Mm.
ideally should be reported by a cytopathologist. So if you want to have the 100% or near correct diagnosis, with the cytopathology is something that most oral or head and neck pathologists do not practice on their own unless they have a subspecialty. So therefore, to start with, it is better if you have a FNAC or the cytological smear. If the oral pathologist is not familiar with the technique, I think better to get the opinion from a cytopathologist. But when it comes to cancer, around the world, as you correctly said, not many people use cytology to diagnose the oral cancer. Now you must be convinced why it is so, because all these histopathological parameters that I showed you, which have a lot of influence on treatment planning, cannot be assessed with cytology. It's cytology is okay as a screening tool, right? As a screening tool, I am 100% with you, so we can use it, and we can identify dysplastic lesions. Uh, but for cancer, I always think, in addition to cytology, if you have a cytology for a quick diagnosis, okay, but you should have an incisional biopsy to get all these histopathological parameters that I have been talking about.
Okay. Like it's not a substitute as such, but do you recommend in all cases we should go for a cytology, since it is easy to perform and probably we may get at least some initial information about the behavior of the lesion till the time the incisional biopsy is been done, because it requires again blood testing, incisional biopsy, and then the patient may, or in the circumstances where we are working, it is a little difficult for the patients to convince for biopsy also.
Yeah, it
So,
depends on the circumstances. If you are working in a rural area in South Asia where the facilities are not available, if you want an immediate diagnosis, if you have experienced oral pathologists on site, SME would help. That would help. But as a routine thing to diagnose oral cancer in an established center, but I do not recommend.
yeah, that's there. We should go for a biopsy. That
Yeah.
is, it can be used for a mass screening, like in the camps we are arranging. There you can collect the smears and find out if some alterations are there, and if at all some mild dysplastic changes can be noted on the cytology. Sir, there is one more question. Like you have talked about FNAC also. Now, doing a FNAC in any lesion, now we are talking about oral lesions. How do you advise that a clinician should do the FNAC and then submit the sample to the oral pathologist, or the oral pathologist himself should do the aspiration and take the sample immediately for assessing this thing?
A good question. If you ask me what I prefer FNAC's patients to be sent to me. I am comfortable to do the FNAC and report, because then you know the clinical scenario correctly.
Okay.
Because always you have to compare the clinical scenario with what you see under the microscope to come up with the. We are bound to get a lot of wrong diagnosis, but cytology is not a very frequent thing for oral pathologists. It is always better if the oral pathologist is equipped to do it. But we need to remember, in a lot of general pathology department, the pathologists do FNACs.
Yeah.
But some surgeons do FNACs. That protocol different from one institution to the other. But both parties can do. But in my personal preference, if I am reporting on FNAC, I rather like to do the FNAC myself.
Okay. Okay. Thank you, sir. Thank you very much. Please share your contact details, sir. We'll be needing your guidance further.
Yeah, okay, I'll put it in the chat box.
Yeah, email ID put. Honika, madam, you are not
Yes,
audible.
yes, sir, yes, sir, yes. Sorry for that. So there is one more question, sir. Tilakarat me, sir. What is the most important reason for malignant transformation of OSMR as per your extensive research?
What is the most important reason for malignant transformation?
Yes, sir.
That question is not very clear.
Malignant transformation of oral submucous fibrosis.
Yeah, I know.
Yes, sir.
Yes,
Yes,
what is
sir.
the most important reason? That part is not very clear. But malignant transmission of oral submucous fibrosis, we have worked extensively on this. It's a very complex process. Malignant transformation, of course, if you ask the degree of dysplasia for whether it's submucous fibrosis or not, the degree of dysplasia is one of the most important things. Higher the grade of dysplasia, more the chance of malignant transformation. Uh, of course, the research have shown, although not in practical use, various molecules are responsible for malignant transformation more over some other molecules. So that's the extensive area to talk about. But if you look at not the research but the day-to-day practicing, if you have oral submucous fibrosis patient with higher grade of dysplasia, that patient should be followed up much more than a patient without dysplasia or having mild epithelial dysplasia. So that is the usual practice. But there are various mechanisms, but if that particular person wants our research, I can send our reviews as well as the research papers on pathogenesis and malignant
Yes.
transmission of OSM.
Yes, sir.
Yes.
Sir, if you permit, should I add something? Like if you
Yeah,
permit,
sure,
sir.
sure.
Yeah. In fact, what is this thing? Our observation is OSMF has got a less malignant transformation as compared to the other oral potentially malignant disorders, because the fibrosis which is occurring in the lamina propria and connective tissue, that itself is preventing the dysplasia to occur. So that has been proved by the previous review of literature. And if at all it happens, it must be of a severe case like the OSMF. So, I mean, that's the point which I wanted to highlight.
Thank you, sir. Sir, there is one more question. Did you find any region-specific variation in the degree of dysplasia in OSMR, sir? Any region-specific variation in the degree of dysplasia in OSMR?
Region-specific dysplasia, this is a subject that we discuss in some forums, the site specificity of dysplasia. Whether it is submucous fibrosis or normal mucosa, dysplastic features have some site specificity. Some features you see more frequently than others in a particular site. So that is why some people think of whether we need site-specific dysplasia grading. But already we are in a very complex grading of epithelial dysplasia with increasing 16 features to 28.
Yes.
So I feel I'm also responsible for that, introducing that many features in the WHO.
Yes,
But but it is complex. But what we need is to take site as a risky site rather than the giving different dysplasia gradings. Clinicians know that if they have a lesion, dysplastic lesion, the floor of the mouth, soft palate, lateral tongue, they have a high chance of transformation over dysplasias in the buccal mucosa or lip or commissure, for example. So that is what is most important thing. The pattern specific, site specific patterns in dysplasia, the research are going on, but still we do not have very specific answers that we can implement in practice.
You're again not audible. Dr. Honika, you are not audible.
Sorry, sir. Sorry for that.
Yeah.
Sir, I have a personal question, sir. Like any
Sure.
standard IHC panel to be followed in a case of undifferentiated tumor, sir? Like any standard IHC panel?
For you are referring to carcinoma or sarcoma or melanoma or what? I'll tell you the practical thing. If you have
Yes, sir.
undifferentiated cancer in the mouth, so that is where you seek for, as I showed you, immunohistochemistry help. Right.
Yes, sir.
When you have a large cell undifferentiated malignancy, now the first thing you got to decide is whether it's a carcinoma, sarcoma, melanoma, or lymphoma. Very
Yes.
straightforward. And then your primary panel should be to decide that what the lineage of the tumor, right? You do a cytokeratin, you do a S100, you do a leukocyte common antigen, and if you want, you can do a vimentin. So that will answer that, not 100%, but you can get some guidance whether you are looking at a carcinoma, lymphoma, melanoma, or sarcoma.
Yes.
So then you go for your other, if it is leukocyte common antigen positive, then you have the lymphoma panel. If it is, vimentin positive, all others negative, then you go for the sarcoma, depending on the morphology, various markers. So that is how you should approach diagnosing undifferentiated tumors. Yeah, it's a big subject. We can talk about one day, one whole day.
Yes. Thank you so much, sir. It was a remarkable lecture, sir. Thank you.
Thank you.
As we move forward, it is time to welcome our next distinguished speaker. Today, we have the privilege of hearing from a distinguished academician and innovator in the field of oral medicine and radiology, Dr. Abhay Kulkarni. Dr. Kulkarni is currently serving as a reader in oral medicine and radiology at MID SR Dental College, Latur, while pursuing his PhD at Sinhagat Dental College, Pune under MUHS Nashik. His journey began with graduation from VPDC, Sangli in 1995, followed by private practice, and later an MDS from PCDS Bhopal in 2012. He went on to contribute over 12 years of dedicated service at PDU Dental College, Solapur. An accomplished scholar, Dr. Kulkarni has 42 publications to his credit, including 8 national and 4 international papers, and has authored 5 subject-related books along with 4 books on dental awareness in multiple languages like Marathi, Hindi, English, and Kannada. His creativity is further reflected in 10 copyrights for original concepts granted by the Government of India, and he has applied for 3 patents for new instruments. His excellence has been recognized with prestigious honors such as the Avishkar Award at the university and in inter-university level by MUHS and the Charaka National Award for Clinical Dentistry. Beyond academics, he has also authored a spiritual book in Marathi and is actively engaged in tobacco control and cessation initiatives in Latur and surrounding regions. With such a remarkable blend of scholarship, innovation, and community service, it is an honor to welcome to this conference a visionary educator and researcher, Dr. Abhay Kulkarni, sir. Sir, the stage is yours, sir. Please continue with the presentation.
Yeah. Is my screen is audible?
Yes, sir. Your voice is audible and the screen is visible, sir.
Yeah, my first slide, good evening. It is visible?
Yes, yes, sir. Yes, sir.
Okay. Okay. Thank you very much, Hodika madam, for a wonderful introduction. And thank you all team members for taking me in this prestigious conference which is arranged. Thanks to Nural sir especially, who's been I've been with him since last 2 years probably, and probably this is to a second or third occasion we are working together. And I'll start with my presentation. Good evening all viewers, and just a minute. It's locked. Yeah. This is my topic of presentation: salivary metabolites in oral malignancies and tobacco uses. As introduced earlier, this is my contact details. If somebody wants to have a word with me, can have word. In short, the introduction: metabolomics is a systemic study of metabolites, which are small molecules generated by the process of metabolism at cellular level, tissue level, or of whole of organisms. It includes wide range of metabolites like lipids, peptides, amino acids, nucleic acids, vitamins, organic acids, carbohydrates, and thiols. Nicholson defines metabolomics as the comprehensive quantitative analysis of all metabolites of an organism or a specified biological sample The term metabolomic profiling is also used simultaneously. It is a unique chemical fingerprints of low molecular weight of a metabolite profiles. These are the indicators of physiological or pathological states and can provide information for identification of early markers of the disease and help to understand its occurrence and progression. According to Milansky et al., out of 1840, almost 500 metabolites have been identified in the oral cavity, and in that 359 were found in saliva. Saliva offers many advantages compared to the other biofluids as it can be collected safely with less training and can be produced on demand. Despite of many advantages of saliva, it is considerably less studied for metabolomic profiling compared to the fluids such as urine and plasma. Saliva contains a large repertoire of proteins and peptides which are found abundantly in a plasma too. This is a consequence of exchange of molecules with a crevicular fluid at the periodontal pocket of sulcus through passive diffusion, pinocytosis, and fusion pores of acinar cells. This way, saliva can be a very important biofluid regarding hormonal, immunological, and nutritional and physiological status of an individual. Salivary metabolite analysis is a non-invasive, rapid, and inexpensive strategy. Since cellular metabolism is altered by disease, resulting in metabolic effects, may serve as a biomarker for any given pathophysiological conditions and also can be implemented for mass screening easily. To detect the metabolites, the methodologies available are GCMS, SPME, NTME, TFME, SBE, direct injection mass spectrometry. Gas chromatography hypernated with mass spectrometry, that is GCMS, is one of the most popular analytical platforms for volatile metabolite profiling and considered as a gold standard of a metabolomic research. As the name suggests, in this methodology, the volatile metabolites are loaded in the GC column and are separated metabolites then detected by mass spectrometry. The samples that are not volatile under normal conditions can be derived to make a metabolites thermostable and gaseous at a higher temperature. Compared with other analytical tools such as a liquid chromatography, mass spectrometry, and capillary electrophoresis mass spectrometry, GCMS is one of the most efficient, sensitive, and reliable tools for metabolomic studies. GCMS produces reproducible molecular fragmentation patterns, making it an integral tool for a metabolomic identification. GCMS has shown separation efficiency, which can resolve very complex biological mixtures. This technology identifies and quantifies a few hundred metabolites in a single sample. What is the need of a study? At present, the biopsy is considered as a gold standard for diagnosing the oral cancer, but the invasive procedure is a major drawback of this method. To overcome the drawbacks of a traditional diagnostic methods, there is a need for an adjunct diagnostic tool for early accurate diagnosis of oral submucous fibrosis and oral cancer in highly prone population. So aim was to evaluate and compare the metabolites using GCMS in saliva of oral cancers, OSMF, tobacco users without oral lesions, and non-tobacco users. Some review of literature, Shobhase Tantre et al. Included histopathologically confirmed oral squamous cell carcinoma and oral leukoplakia patients and a control group, and found 15 compounds differed significantly between control OLK and OSCC. Marina de Silva et al. Salivary metabolite samples from 27 oral squamous cell carcinoma patients and 41 control individuals were compared and found some changes, but claimed further studies to be needed with a larger population. Leone and Rofer 2021 in their study found 9 out of 84 were positively associated with 5 years tooth loss and concluded that untargeted metabolomic profiling of saliva replicated metabolomic signature of a periodontal status and revealed novel metabolites associated with periodontitis and the future tooth loss. That it indicates it has got a role in other diseases also other than the oral cancer and oral submucous fibrosis. Fidalgo et al. Concluded that children with the caries lesions presented higher levels of several metabolites, including lactate, fatty acid, acetate, N-butyrate, and permanent dentition presented increased level of acetate and saccharides. This is another example. Gokul Sridharan studied salivary metabolomic profile of oral leukoplakia and compared with normal controls. A range of salivary metabolites were significantly altered in oral leukoplakia and oral squamous cell carcinoma. Ravindra Taure et al. In their study, 59 human subjects studied head and neck cancers 32 and control 27 and identified 48 volatile organic metabolites. The metabolites were significantly different from healthy control. Daniel C. Mueller studied saliva of smokers and non-smoker metabolites. obtained a 24 hours diet control study, and they could find 13 significantly altered metabolites in the signature in the smokers. That also shows that it has got a role in detecting all these effects. Zaivi et al. Explored salivary metabolomics in oral cancers and oral leukoplakia in healthy individuals, and utility of salivary metabolites diagnostic for oral cancer was successfully demonstrated. So the patients were selected in the 4 groups, that is group 1, group 2, group 3, and group 4. Then the collection of 5 ml of unstimulated saliva by spitting method and rinsing mouth with the chlorhexidine after rinsing the mouth. Then storage in the glass vial and transportation of a saliva at minus 80 degrees centigrade and processing for gas spectrometry, mass spectrometry. This way the saliva samples were labeled, and the saliva samples were stored, and then they were sent for the GCMS analysis. And this way the report came, and the matching, the GCMS has got its own library. So the matching of the metabolite which has been shown, which is considered to be 70 and 70% above, was been considered in the calculations. So the calculation detected out of 55 patients in each group, number of metabolites were higher in oral submucous fibrosis than in oral cancers, than in tobacco users with lesions and non-tobacco users. The total of all percentage, that is 70% metabolite matching we had considered. And according to that, again, it was higher in the oral cancers, and then it was in the tobacco users. And average patient percentage was higher in the tobacco users compared to the other these things. So it has shown a variable findings in all these things, which are contradicting to the previous literature studies. So this is a comparative graph analysis of a number of metabolites which is being seen, and it is shown highest in the oral submucous fibrosis, and that has been again a contradictory finding to all the previous review of literature which has been studied. So number of metabolites and total percentage was matching, and this way it has been shown. Then, since there was a doubt whether how it has been contradicting the previous literature, so we did a new parameter study. The area covered by all the metabolites. We calculated all the metabolites. Some of them were unknown and some were known, and we calculated the area which has been covered by the metabolite, and it was been 2355.413 in oral cancers. These are the metabolites. OSMF showed 2302. Then tobacco users again highest, that had come to 3404.43, and the non-tobacco user showed 2453.93. So these are all the different metabolites. So in short, the total area covered by all the metabolites in the different group, and out of that, the percentage in the oral cancers were 22.39, while the OSMF was 21.88. And the highest percentage was in the tobacco users without oral lesions, and then it was 23.36 in the non-tobacco users. That again probably was the real going near to the percentage which was been present in the oral cancers. So this is the comparison, like the oral cancers patients and the area occupied by this graph, which has been highest in the tobacco users as compared to the other groups. And this is a comparison of the number of metabolites. The down graph is the number of metabolites, while the up graph, the area covered by the metabolites. That is again a contradictory finding. So further studies are needed with taking this kind of the populations and in the different areas, and with the same methodology again to study and come to a conclusion. But right now, what has been shown to us is number of metabolites showed more number from control group to the oral submucous fibrosis. These findings are in accordance with the previous literature. So salivary metabolite can be used as a tool for screening in OSMF. However, it showed decline in oral cancer, which is not in accordance to the previous literature. This has to be evaluated with further larger sample size. The areas covered by all metabolites were measured for the first time, and the area covered showed slightly more prevalence in oral cancer compared to OSMF, while it is significantly higher in the tobacco users without oral lesions compared to the other groups too. Conclusion: the salivary metabolomic profile is a mirror of the body, as it can provide a general outlook on a significantly changed metabolomic from the aberrant enzymatic regulation capture the oncometabolites, and highlight the altered pathways. All of these can become ideal metabolite markers indicating diseases without obvious pathological symptoms. It can be considered as a risk indicator of various diseases. Then it has got a limitation that the concentration can be diluted to some extent because of a continuous saliva secretion, mainly by the major salivary glands. And even the areas covered by the metabolite should be considered along with the number of the risk indicators. The concentration which has been diluted in the saliva, that can be studied by taking the original composition that at least we can collect from the parotid duct. The direct original saliva can be collected from that, and probably we are doing further research on that. These are my references. Thanks and regards.
Thank you, sir. Your insights have added immense value to this session. We welcome your doubts or any queries from the participants.
Yeah, anybody's got a query?
Right now, no, sir.
I have a question for you, sir.
Yes.
Sir, I wanted to ask, we are talking about so many metabolites. So is there any one particular metabolite which we can target and later we can standardize in the future so that it can be used for mass screening as such, as an invasive procedure?
Yeah. Basically,
Non-invasive.
it's not an invasive procedure because we are just collecting the saliva, right? So targeting a metabolites, that again be a study. Like I can right now find out which all metabolites were higher in a percentage in my case, and that I can prove a data. And afterwards, some researchers can take that metabolite, seeing it. But see, again, like targeting a metabolite will be like having you are specifying that. Anyway, you are collecting the saliva and again you are subjecting it to the GCMS. Then why you want to only study that part when you can study along with all the part? Am I clear?
Yes, sir.
So targeted metabolites, like it has been proved previously that 2-3 metabolites are been dominant in some diseases. Like I have got a review on not only the oral cancers and potentially malignant disorders, but even the periodontal diseases, even the some systemic diseases like diabetes, hypertension. It has been proved that some of the metabolites has been dominating in some diseases. So you can work always. You can work with a targeted metabolite. I agree that, but it's a simple thing. Like if we can correct with the same without changing a methodologies, more information can be corrected. So better to go as having a blind approach of untargeted metabolomic profiling. That's what I suggest.
Okay, sir. Thank you, sir.
Yeah, there is one more question which I
Yes, sir.
could read.
Yes, sir.
Should I go for it?
Yes, sir. Yes, sir.
Your inputs on salivary versus serum metabolomics for OPMDs and oral cancers. Well, again, this is a topic of a debate also. Even I had got so many articles which I had got to tell you, this is my thesis topic and for which I had worked extensively, and then I have selected this topic. So saliva, comparing a saliva and serum is always again, I mean, it always goes on, but giving an input on this, like both are reliable tools, and we prefer saliva. Why? Because we are moreover dealing with oral lesions, and it is quite likely that some local contaminants and the local contact of the lesion with the saliva probably have a more additive value. So at least for the oral lesions and oral diseases, my personal opinion is to go for a saliva rather than going a serum, because serum again has gotten this thing, I mean invasive this thing, and you need to take this thing, blood collection and all these things. So patient won't be easily ready for that. So I mean it cannot be compared as such, but both are the reliable tool. That's what my answer is to this question.
Yes.
Sir Tilak Ratne, sir, your view on this? Epsin, ma'am, anything like you will like to comment this thing?
So shall we proceed with the next presentation, sir?
Yeah.
Thank you, sir. Now I invite Dr. Efsin Somi, Associate Professor, Faculty of Dentistry, Department of Oral and Maxillofacial Surgery, Ankara, Turkey, to kindly moderate this session and introduce our next distinguished speaker.
Hope you can see my slides. Can you hear me?
Yes, sir, you're audible and
Okay, perfect.
slides are
So,
visible.
I would like to thank Dr. Nurul Anwar as the organizing chairman, and also the organizing secretary, Dr. Efsin Somay, to let us being all together and discuss all the specific topics in an environment that everybody is really keen on their topics and really would like to learn more. So today I am planning to talk on radiotherapy and risk of osteoradionecrosis in the next 20 minutes, 25 minutes. And these are my disclosures. Basically, I have no conflict of interest aside being a radiation oncologist. So let me try to get rid of the topic in the hat. So do you know how I can dismiss the controls at the top, because I cannot see my slides? Okay, no worries. I'll go into detail. So I'd like to go into detail, starting with radiotherapy and the evolution of radiotherapy, because in the last 20 to 25 years, there is a great evolution, starting from two-dimensional radiation treatments, coming to IMRT and volumetric modulated arc treatments, which has also been built on image-guided radiation treatment. In the years of 90s, at the beginning of 2000s, we were really treating our patients with two-dimensional radiation treatment. As you can see here, there were direct hits, direct films, and there's nothing else. So we didn't have any objective way to comprehend those to the organs at risk, and that's directly having blocks on the two-dimensional fields, and using these copper blocks, and we could not really shape any additional treatment fields to decrease the dose on the organs at risk. And when we had tomography, we had a three-dimensional conformal radiation treatment, because we have the ability to have dose calculation on the CT images. So we could understand how we can cover and conform the targets. So the aim was to define the dose on the desired area and decrease the dose on the organs at risk. So initially, at the time, even at the time of three-dimensional treatments, if we could not use additional fields, the field was like this. So the mandibula was directly in the field, because we could not really shape the field with only the blocks. Then came the multi-leaf collimators instead of the cerebral blocks, and the field could easily be fixed with different perspectives, and we could at that time play with the field, cover the area with the desired dose, and spare the organs at risk. So we started using those volume histograms, and this is an example showing that the high dose was delivered to the area which we desired, and the rest of the organs are receiving less dose. But what was missing in three-dimensional conformal radiation treatment was directly with the forward planning, because forward planning means eating the meal first and then calculating the calories, because we were enframing the target tumor, we were calculating those to the tumor and organs at risk, but we had no other option. We could not choose a better optimization. So we need intense modulated radiation treatment, which we started using around 2003, 2004. and this was called inverse planning. Basically, it is eating based on the calorie need. And this was based on a radiation beam being divided into beamlets, which were ranging from 0 to 100 in intensity. So basically, we were defining the field with not only black and white, but there are lots of gray areas based on our needs. So this is called inverse planning, and user states desired goal. Planning system suggests an optimal solution, but at the end, the physician was deciding what needs to be delivered. Take IMRT as not only 2 angles, not only 4 angles, but as much as angle needed can be delivered with intense modulated radiation treatment. However, after 9 fields generally, there is no additional benefit in this. What are the pros and cons? I mean, the oral cavity, parotids, brainstem, spinal cord, mandible could easily be managed with IMRT to decrease the dose in the organs at risks. And as you can see here, the tumor area could easily be boosted with IMRT with a very higher dose. However, it's not enough because we could only use 9 fields or 11 fields. So we need at that time a rotational treatment which can deliver a 360 degrees of freedom for volumetric modulated arc therapy. So this is called arc IMRT, and not only 9 fields, not only 11 fields, but 360 degrees could be used as fields to be shaped the field. And as you can see here, all fields can be divided to 0 to 100 in intensity. So you can shape a smoother field, smoother dose distribution, as you can see in the examples here. And this is a VMAT, this is an IMRT. There in IMRT, you can see that there are spikes. In VMAT, it's much more smooth angles, and you don't have any spikes. Then, with the invention of IMRT and VMAT, we could get the idea that we can deliver a very focal high dose in the field while we are sparing the rest of the field. So, and this was called simultaneous integrated boost radiation treatment. And in the last 15 years, almost all our treatment plans are based on a simultaneous integrated boost radiation treatment. This is a nasopharyngeal cancer, for example. The dose, the yellow dose is 57. The blue dose is 63, and the red dose, which covers the tumors area in the nasopharynx and in the neck, with 70 gray. With VMAT and simultaneous integrated boost technique, we could easily spare the oral cavity and mandible. As you can see here, the oral cavity is spared, the anterior mandible is spared. The high dose is not in the mandible, as you can see here. The dose is just delivered to the node and the contralateral node here. The larynx could easily be spared. So this allowed us having patients with less difficulty in swallowing and with less vocal impairment. Focused dose really decreased the high doses in the organs at risk. As you can see here, there's no high dose in the mandibular here and no high dose on the contralateral pharynx. And ensuring mandible is not receiving high doses and sparing parotids to decrease the dry mouth allowed us more tissue spare in the oral cavity and the salivary glands, and this helped us to have happy patients near the end of their treatments in that 30-day or 35 or 33 days of treatment, having at least saliva near the end of their treatments and be able to eat and swallow easily. So following the VMAT, we had lots of options in volumetric modulated treatment. And we know from the beginning that volumetric modulated treatment is better than IMRT. And this was also easily be delivered with tomotherapy approach. So volumetric IMRT techniques provides better organometry sparing in comparison to IMRT, and this was being known since 2008, 2010, 2012. And IMRT VMAT decreases toxicity because xerostomia decreased with this newer approach, and when xerostomia decreased, the grade 3 mucositis, grade 3 dysphagia decreased, especially the percutaneous enterogastrostomy rates decreased, not only at the end of the treatment, but also in follow-up after these treatments. And as you know, when we were treating with radiation, the concurrent chemotherapy specifically increased the problem because the radiation can be sparing the organs at risk. However, when we deliver concurrent chemotherapy, the fast-growing skin, fast-growing epithelium is also injured by chemotherapy. So the acute mucositis, the dysphagia, increases, especially in the third week, fourth week, and fifth week. So this increases the mucositis and oral problems. And the problem here is IMRT and VMAT, the toxicity might be directly related to dose band, because while we are using the 360 degrees, or let's say 12 angles in IMRT, we need to give low doses from somewhere to focus the dose in the center. So this brings toxicity in the lips, toxicity in the tongue, toxicity in the skin, in the hair skin. So you can easily see the line in the mucositis and the dry mouth. So this ends up with the weight loss. So we need to be careful about what we will be causing in the treatment. So we need to be supporting our patients with the care during the treatment, not only for fillers, but also the nutrition, the exercises. And you can easily see the mucositis where in a patient where we deliver an ipsilateral treatment on the left. On the right side, there's nothing, but on the left side, there's an increased mucositis. So this brings the pain. So the most important variable in modern technology is not the beam, but the team, because whatever we do is at the discretion of the physician. So the radiation oncologist should be aware of the indication, the targets, the countering based on not only the tumor, but also the organs at risk. But he or she needs to know the prescription and how it will affect the organs at risk or the area being treated. So we need to be careful about the margins, coverage, and hot or cold plans in the approval stage. So what about osteoradionecrosis? You know, the pre-radiotherapy evaluation is really necessary for the cancer patients for dental considerations, because we don't want to face osteoradionecrosis afterwards. But there are lots of pre-radiotherapy evaluation classifications for oral tongue and for the mandibula or the lesions. And as a group, we have really focused on this for a long time. And we can easily say that we should be aware of what the patient will receive during the treatment. So we need to be careful about the osteointegration related with the tooth extraction, and is it necessary to have a tooth extraction or not? And what about the current status before the radiation treatment related with the mucosa, the trismus, the dental evaluation requiring any dental fill or not? And how about the oral hygiene, whether the patient is being smoking currently or not? So we need to be aware of the periodontal and dental infection from the treatment, before the treatment. We need to treat that. And if any dental extraction is necessary, we need to be really doing that before the treatments, before the radiation treatment, because we know that post-radiation tooth extraction really is a great factor for osteoradionecrosis. And preoperative tooth extraction is also recommended if it is possible. There are lots of studies based on that, but we need to be sure that tooth extraction is necessary. If it's not necessary, we can easily go ahead and do the dental evaluation, and we can treat the periodontitis, etc. But if it is necessary, we should be putting time between the tooth extraction to radiation, and it needs to be at least 2 weeks. So we need to treat all active dental caries and periodontal disease before radiation. And during radiation, we need to be, again, using dental evaluation, cleaning, neutral sodium fluoride, oral hydration. Oral hygiene is important. We need to be away from alcohol, and we need to be very careful about the mandibular and maxillary doses during the treatment. There is a guideline, different guidelines, and in NCCN there is a lot which has not been changed in the last 10 years, saying that be aware of what toxicity can be caused with radiation and try to spare as much as mandible, as much as salivary glands, as much as parotis that you can spare, and have the patient during the treatment that the xerostomia is not increasing and the oral hygiene is not causing any major problems during the treatment. So as you can see here, this is a nasopharyngeal case with a very large tumor treated with VMAT. And in this case, that you can easily see that the mandible is spared while we're delivering a very high dose to the tumor here, and also the maxilla is spared for the tooth, which can need extraction in the future, maybe not in 2 years, but maybe in 5 years. So we need to be careful about the delivered dose, and radiation dose distribution in the teeth and maxilla and mandible is very important. So we need to be checking how much dose is delivered in our plans. So we can easily say that, is it related with the area we treat? Well, basically, yes. However, it's not directly related to where we treat, but it's directly related to dose which is deposited in the mandible or maxilla. So while we are treating the maxillary and the mandibular area, oral cavity, oropharynx, hypopharynx, nasopharynx, and parotid tumors, so be careful about the dose on the mandible and maxilla. When you are treating maxillary tumors, again, but when you are treating the mandibular area for specifically the gland tumors or the nodal disease, be careful about the mandible because those matters. We can document them, and it is recommended to document them in the area you treat. So ALARA, as low as reasonably achievable dose in the axil and in the mandible and in the maxilla area is really recommended. So one of our works is directly related with the assessment of the impact of osteoradionecrosis on quality of life, measures in patients with head and neck cancers, and the basis is a dentist should see the patient beforehand and evaluate that patient for the future during the treatment and after the treatment. And we need to be sure and document about the treatments, about the dental caries, about the need for tooth extraction, and we need to be sure that these patients needs to be seeing the dentist not during the, not before, not during, but all the time, also after the treatment. And there's no consensus, unfortunately, on osteoradionecrosis for a long time. And there are many medication with osteonecrosis of the jaws, or Landsoma score, or common toxic criteria scores, until 2025. So as a group, we had an interdisciplinary modified Delphi study specifically to define and address the unmet need of orodental radiotherapy associated late effects. And this is an oral consortium specifically which was built to define the osteoradionecrosis. It really worked on bone disorders, radiation injury, loss of blood flow or vascular insufficiency. And we have asked lots of questions based on that. It's related with the exposed bone, it's related with the mucosa being intact or not. It was directly related with the toxic grading system, the severity of the osteoradionecrosis, and it's also related with the symptoms the patients were having, and whether it's related with the pathologic fracture or not, whether there is an exposed bone or not. And the consortium strongly recommended the adoption of osteoradionecrosis-focused multidisciplinary team, and the follow-up of team from the beginning to the end, and including serial photographs, medical records based on what we do from the at the beginning and at the end. And overall, the clarification of the osteoradionecrosis is a radiographic lytic or mixed sclerotic lesion of bone and or visibly exposed bone and or bone probed through a periodontal pocket or fistula occurring within an anatomical site previously exposed to a therapeutic dose of head and neck radiation treatment. This was perfect. This was not directly related with the time bias. However, it was lacking something. It was lacking the dose details. So as a description, it's finally there. However, we were lacking the dose description here. So the review of osteoradionecrosis is really important related with the dose delivered. And ionizing radiation on the mandibular bone causes lots of problems, and at the end, it might cause osteoradionecrosis based on hyperinflammation, vascular occlusion, hypoxia, anoxia, hypovascularity, hypocellularity. So we need to be sure that mandible, wherever we treat, we need to be sure that mandible is not getting high dose, more than, as low as possible during the treatment. And we should ensure the ALARA as low as reasonably achievable dose on the mandible and maxilla. Then also in many papers, most of the time, the site is cited, saying that because the oral cavity is treated, because the oropharynx is treated, but not the oral cavity, not the oropharynx. That's not the important part. But the dose to the mandible is important, not the total prescribed dose. I can deliver 60 gray, I can deliver 70 gray. That's not important, but the dose to the mandible matters. As my peers, and also I can say that one of my mentors, Dr. Topkan, noted that this is underrated. So mandible matters, the dose to the mandible matters. And we can say that 25% of the mandible receiving 10 gray or 50 gray or 70 gray is mattering. And recently, we can easily say that in 2016, which was published in January, we can easily say that the 25% receiving 50 gray or more are doing worse. So they have a higher risk of osteoradionecrosis. Also, if we have pre-radiation dental extraction, they might be doing worse because probably having an hypovascular, hypocellular area. And also the men are doing worse, probably related with smoking. So aside from radiation, what do we need to know for osteoradionecrosis? I can easily say that Topkan's CAR weight loss scoring is directly related with the tooth loss because C-albumin protein to albumin ratio and also the significant weight loss is directly related with weight loss. Directly related with tooth loss, and it's also related with the osteoradionecrosis. And Valerius index is directly related with osteoradionecrosis. We can easily say that if we have, during the treatment, if we have a low hemoglobin before we start the treatment, it can cause an osteoradionecrosis. If we have a peer chemoradiation, high platelet count, it can be a risk factor for osteoradionecrosis. If we have pre-treatment hemoglobin to platelet ratio, which can be really stratifying patients for osteoradionecrosis or not, that's a point to be clarified before showing that a high inflammation in that patient, which can cause osteoradionecrosis. We can easily say that peer-chemoradiation pan-immune inflammation value is important. If these patients are having high inflammation before their treatment, they are candidates for osteoradionecrosis. So we need to be careful about if these patients are having high inflammation before the treatment, they need more care in comparison to the normal patient without inflammation in our clinics. So aside from predictors, aside from radiation, we also need to be careful about the drugs these patients are using. And there are many guidelines, but as a summary, I can say that if the patient is receiving methotrexate, you need to be careful about osteoradionecrosis. If these patients are receiving monoclonal antibodies like bevacizumab, be careful about osteoradionecrosis. If these patients are receiving protein kinase inhibitors, I mean, radiation oncologists should be careful. Dentists should be careful. The medical oncologist, the surgeon should be careful. Like cabozantinib, sorafenib, sunitinib, aflibercept, we need to be careful. Biphosphonates, I mean, that's another big problem during the treatment, after the treatment. Alendronic acid, chlordronate, etidronate, ibandronic acid, risedronate, pabindronate, zoledronic acid, denosumab. Be careful about osteoradionecrosis. And the time, I mean, if the patient is using this for only 1 month, it might not be a major problem. If these patients are using these for a long time and still using it, be careful about osteoradionecrosis. So overall, as a summary, I can say that one size does not fit all. And radiation dosimetric factors are the most influential of all risk factors. So whatever we do as radiation oncologists, we need to be careful about that. Modern radiation is more precise, but still toxic to bone. So those matters. And osteoradionecrosis is influenced by a wide variety of confounding factors. There are many indexes. And in the recent ones, we are there as a group. So these can predict osteoradionecrosis and the groups who might require more care. Be aware of all systemic treatments to decide dental trauma, and basic is the multidisciplinary care. We need to be all together to spare these patients, to cure these patients, to help these patients, and this is not optional. And care before, during, after radiation is lifesaver, and goal is the multidisciplinary management. So I'd like to thank for your attention. I can get any questions and I try to answer all. Thank you. I cannot hear you, Dr. Sumay. Still can't hear you. I'm sorry.
Ma'am, you're not audible, ma'am.
Oh, I can hear you now. Okay.
No, she's still not audible.
Yes, sir.
Yeah. Sir,
Tomai, ma'am, you are not audible, ma'am. Could you please check the mic once? Yes, sir. Continue, sir. Abhay.
sir, good evening, sir. This is Dr. Abhay Kulkarni. Thank you for a wonderful session, sir. Actually, it is not that much related to the topic which you are covering, but little I wanted to guideline from you. Like during radiotherapy, to protect the surrounding this thing, like tissue integrity, or even like and if you are dealing with head and neck cancers, the salivary glands especially. Should we follow some measures for that? Like, can you suggest something for that?
If I understood you correctly, because the sound is going and coming, for the tumors that we are treating, what we can do additionally to spare the saliva. Did I get it right?
Yeah, same
Okay.
same thing.
So I could not go into detail much because of the time limitations, but the exercise, I mean the chin exercise, neck exercise, help these patients a lot during their treatment and after their treatment to massage the parotid glands and also the salivary glands and support the blood flow to the oral cavity and the gum, and this decreases the xerostomia in addition to the supportive care which is recommended during the treatment, and we have specific nurses to follow these patients during their treatment, whether they are using their gargles, oral solutions, whether they are brushing their teeth, if their dental problems are arising. We always ask our dentists to see these patients during their treatment, and we also give additional analgesics during their treatment to help their swallowing, because continue to swallow during treatment is also helping the saliva to be continuing, because most of these patients have an understanding that if they don't eat, if they don't swallow, and the pain is not increasing, and after completion of the treatment, maybe in 1 month, they might swallow better. That's not a good way of understanding. So we always push these patients to make their oral evaluations, oral care, and eat and drink during their treatments to help their saliva to continue.
Thank you, sir.
Thank you.
What I wanted to highlight you additionally, like during giving a radiotherapy, the radio protective equipment what we are using, can those be additionally used to protect the surrounding tissues, salivary glands, or like if you can, I am designing some equipments. That's what I wanted a suggestion.
I see. It's not routine and it's not really common in many departments. However, the laser treatments or the contact treatments that you can perform seems like helping these patients. However, for example, in our hospital, we don't have that approach and we don't have that facility. So I cannot send these patients for those local treatments that you can help them.
Thank you.
Thank you.
Thank you, sir. That was a very enlightening presentation.
Thank you very much.
Yes. Let us turn our attention to a pioneer whose work has redefined neuromuscular dentistry in South Asia, Dr. Raj Ravindran. Dr. Ravindran holds a distinguished academic and professional portfolio with credentials spanning various from Ragas Dental College, Chennai, a PhD from Sorbonne University, France, and advanced fellowships from international institutions including ICCMO, Tufts University, and the Orthodontic World Institute, Spain. He is recognized as the first in South Asia to introduce ULF, TENS, and mandibular tracking technology K7, establishing neuromuscular dentistry as a super specialty practice in 2004. His leadership roles are equally impressive, serving as International Secretary of ICCMO, President of ICCMO Indian Section, Board Member of IFUNA, and reviewer for leading journals such as Cranio and JCal Dent. He has also founded the Department of Neuromuscular Dentistry at Kanpur Dental College, Nepal, the first of its kind in Asia. Beyond academia, Dr. Ravindran is the Managing Director of Indra Craniofacial Pain Relief India LLP and the founding chairman of the Right Bite Sleep and TMJ Pain Care, which operates centers across South Asia and beyond, treating craniofacial pain and advancing dental sleep medicine. His clinical expertise extends internationally with consulting roles in India, Dubai, Jeddah, Istanbul, and Kathmandu. With his groundbreaking contributions, global collaborations, and unwavering commitment to advancing dental sleep medicine and TMJ care, it is a privilege to welcome to this conference a visionary clinician, educator, and a leader, Dr. Raj Ravindran. Sir, the stage is yours, sir.
There is a sincere announcement from here. Dr. Raj is in Brazil now. He is traveling and he went there for giving her his lectures and his training sessions and all. So he's early morning at say it's I think 9:30 at Brazil now. So he would be joining in a couple of minutes. I had just a conversation on a WhatsApp. So just wait for a while. Inconvenience causes deeply regretted. He would be joining in couple of minutes.
Yes, sir.
Dr. Raj has joined on the Zoom room, and I think he's there actually. So, Dr. Raj, we have introduced you, and sorry for I mean, you are in a hectic session. You are in Brazil now. So, over to you. You can share your slide. We have made you co-host. Thanks that you
Okay.
connectivity and you are available.
Yeah, I'm okay. Thank you very much for having me on. I'm always happy to lecture for your forum. Uh, and today's it's a very interesting discussion as far as I'm concerned because we have been doing lately a lot of management for patients who have undergone surgical procedures with regard to malignancies, where there's no mandible, where there are myotomies done. So I'm just going to start sharing my screen. Can you see my screen?
Yes, sir, it is visible.
Okay. Okay, good morning good evening, everyone. I'm currently in Sao Paulo. There is a conference going on with respect to lactation, which is breastfeeding, and myofunctional therapy, and I'm lecturing here as well. So you might be wondering why a dentist is there, but people fail to realize that we can see signs and symptoms of myofunctional disorders even from within the womb. And this is what new information that I'm getting over the past 3-4 days at this conference here. Uh, I'm Dr. Raj. My specialty is neuromuscular dentistry, which is treating TMJ disorders, sleep apnea, even especially with regard to today's topic, reconstructing the bite for patients who have undergone surgeries, which is not looked upon with much great interest at all by, I don't know any surgeon that takes care of the bite. Even if they do, it is basically to get into centric relation. What if there are no teeth at all? And that is a concern where, no one is thinking out loud. There's not much research being done on that subject. We have treated a couple of patients like that. I'll show you what we have been doing. Anyway, this is me. You can find me on Instagram at Doc Raj Rav. That's my name, Dr. Rajesh Ravindranath. My website is tmjsleepworld.com, and these are all the stuff that I have done and I'm currently doing as well. Dental occlusion changes significantly after cancer treatment. Something that, like I said before, is hardly looked into. Especially when there is osteoradionecrosis and the bone is just withering away, and forget the teeth, there's no bone itself. And then when we do a replacement surgery like a prosthetic correction, we are not looking into where the jaw actually wants to be. Because if the muscles are still there, we can still correct the jaw position to an ideal neuromuscular position. If not, you may have treated the cancer or you may have treated the trauma, but the patient might end up with headaches. Well, if there's no condyle at all, then that's a different story. But yeah, I'm talking about situations where there may be a condyle, or when you're replacing the condyle, in what jaw position should you be replacing it? So most of this changes are with regard to malocclusion. There's radiation caries, and I mentioned osteoradionecrosis, as well as TMJ issues, because 90% of all TMJ disorders are myogenous, which is muscle origin in nature. And we go ahead, we do rehabilitation with prosthetic intervention, preventive care, even with pre-treatment dentistry, which means, we want to make sure that everything is fine before the patient is sent for radiation therapy. But the most important thing that everyone forgets is the prosthodontic occlusion. Most of us are dentists here, and I know occlusion is very, very boring. No one likes talking about it. But in this short 20-minute lecture that I have, slot that I have, I'm trying to, let me see if I can make it interesting. Some question that needs to be asked. First of all, what do we use to check occlusion? Most of the time we use whatever we get in our hands and what's available local. Articulating papers at 100 microns, 120 microns, Raj articulating paper. We just get what we get in our hands. In spite of the fact that we know that occlusal proprioception, the proprioception starts at 5 microns. So if there is a 1 micron discrepancy in anywhere in the bite, in both centric and disclusion, that's going to end up with muscle wear and tear. We don't understand that. The whole posture is stabilized on two extremes, which is the first is your bite, and the next is your feet with the ground. So that's how important a dentist's role is. So stop using 150, 120, or even 60 microns, even 8 microns, because proprioception starts at 5 microns. How do we utilize? What do we utilize? We use equipment. There are equipments available that helps us do all of that. Is our bite registration three-dimensionally perfect? Every time we register a bite, all we look for is the pitch. What's the vertical? What's the vertical? What about the yaw? What about the roll? No one seems to be bothered. Why not? The whole mandible sits in a three-dimension plane, not just one dimension. And what controls all three movements? It's the muscles. So if we have the muscles in control, so if your jaw is this way, if the patient's jaw is this way, you're going to be registering a bite for a bridge or a denture in that same way, or even post-surgically, even for cancer patients in that same bite registration, which may be ending up with problems in the future in your TMJ. We are not bothering about it. Does muscle physiology have anything to do with occlusion? Yes, everything. It's not just the teeth like how we were taught. The masticatory muscles which position and connect the mandible to the skull should be the focal point of correct occlusion. So first, correct the muscles. I'll show you an example. And then the jaw, and then be the dentist. Centric relation, it keeps changing every day, the definition. When I was taught, it was the most retruded. Then it became the the most comfortable antero-superior. Now it is the most physiological, like how Dawson said in 1987, it was published. Term is in transition to obsolescence. Even then, we are even now taught centric relation. I just don't understand why. Now, wouldn't that, so for, when you're registering a centric relation bite, what are we telling the patient? Go back, go back. We are not considering what's happening within the joint. When you're going back, you're pushing the TMJ complex into extremes where the tissues inside there are not happy. So the primary aim for any dentist is to keep the stomatognathic system happy. What is the stomatognathic system? It consists of the muscles, the joints, the teeth, and the airway. All four need to be in harmony with each other. Now, to keep them in harmony, the teeth which control the bite. So if intercuspation is the necessary function for swallowing and mastication, but mainly for swallowing. The only time we go into centric occlusion is when you swallow. And we swallow about 8 to 10,000 times a day on an average. So if your jaw is that way, or your teeth is that way, and to maintain centric occlusion, to swallow properly, the body is going to make sure that the mandible moves in a separate trajectory to get into centric. Imagine doing that 8,000 times a day. The muscles that are making that movement happen is going to go faulty. It's going to go awry all over the place. You got to keep that in mind. I have a good illustration for that. There is research that proves that 93% of the entire population has a malocclusion. Imagine. So no matter how malpositioned the teeth are, the muscles will struggle to create a centric occlusion. I show this at all my lectures. What's odd in this guy? You can see his right bicep is more than the left. Why? He may be using it more, lifting weights more. Okay? Imagine the same thing in the face. If this patient is missing a tooth on the left side, she's going to be chewing on the other side. And, for a couple of years at least. And then when she comes to replace that missing tooth, you're going to be registering the same bite. Imagine. And that's going to create TMD. And this is 95% of all my patients. Which is why I've come up with the aerodontics protocol. We teach this at my courses. My next course is in March 26 to 29 in Dubai. So if anyone's interested, please DM me. So it's my protocol for precision dentistry. It's data-driven digital precision in diagnosis and treatment planning. We go through a thorough diagnostic protocol, questionnaire, a big questionnaire, 20 pages, radiology, palpation. Let me see how much ever I can go through here because of the lack of time. So MRI is considered to be the gold standard, but if it's not three-dimensional, real-time with TMJ coils, I wouldn't be that happy with the MRI because it's more expensive as well. I'd rather stick to the CBCT, full volume, so we can measure the arbitrary space within the TMJ fossa. We can see the beaking. We can look for cysts. What is beaking? It's literally form follows function. So people need to understand that I didn't go and get into the deep part of the anatomy. But what is the TMJ? People talk about the disc getting displaced. Why is it getting displaced? First year anatomy. Unlike the other joints, the disc over here is actually a continuation of the superior head of the lateral pterygoid muscle. It's simple. It's not complicated. If you use one side more than the other, the lateral pterygoid on that side is going to get more compressed, more strong, more hypertrophic. When it gets hypertrophic, it becomes shorter. When it becomes shorter, it pulls the disc out. And that's why you hear a click. And the more the bruxing and the clenching and the pull, the condyle shape also changes because it's pulling, it changes. If you're clenching and the masseter is also pulling, you'll find a deeper antigonial notch. We need to start thinking. And if you're going to put a prosthetic replacement for the surgical procedure that you've done, and you're not considering how the masseters are functioning because the patient might still be clenching, then you're going to end up with a patient that might have headaches in the future. Yes, you've taken care of the cancellous growth, but we got to make sure that the patient doesn't have a problem in the future. There's another thing that we look at, the airway volume. We measure from the posterior nasal spine to the epiglottis. It should be about, the total volume has to be about 25 cc. You can see here it's 13. So if it's that narrow during the daytime and the CBCT was taken, imagine what's going to happen during sleep. When the patient goes to sleep, the airway is going to get blocked and forcing the patient to clench. Now, why is this happening? Do you see the gap between the tongue and the palate? This patient has a tongue posture issue. It could be a tongue tie. It could be a tongue posture problem, tonicity, lack of breastfeeding. It could be anything. Habits. It's all about diagnosis. Now, if the tongue is not in the right place, then the whole structure of the skull is, not going to grow the right way. The palate goes in deep. The septum that is on the palate bends. There's going to be a deviation in the septum, which will lead to the nasal airway getting constricted, which would then lead to your tissues within the nose to be hypertrophied, to get inflamed, which would then lead to allergies or chronic rhinitis and other nasal, other airway problems, asthma. And the ENT might even correct that the DNS with septoplasty. But it will come again, it will relapse. Why? Because the palate is still high and deep. There are not enough dentists who do enough growth for adult patients because, and the ENT doesn't know what to do with them. It's just the lack of awareness. We go through a detailed sleep questionnaire for all our patients, even the 2 surgical patients that I spoke about. We check for snoring. It's not a stop bang questionnaire. We measure the sleep patterns with all these equipment. But what is sleep apnea? It's basically, as the word says, obstructive sleep apnea. During sleep, an obstruction within the airway that leads to an apnea event, which means you're not able to breathe for more than 20 seconds. The body has to respond, right? How does it respond? By literally telling the tongue to move forward. When the tongue moves forward, it drags the lower jaw along with it, and the patient clenches. So the clenching is actually the body's response to keep you alive. So it's a good thing, at the expense of the TMJ and the muscles and the whole somatognathia system. So this is what we need to keep in mind. So just giving a mouth guard for a patient who bruxes and you see class 5 abfractions is not enough. Again, you're thinking like a dentist. the mouth guard will only protect the teeth from wear and tear. The patient is still clenching. What that patient needs is a sleep appliance. So why am I even talking about OSA? Because of this. That's how I got into sleep. Sleep bruxism is 95% biopsychosocial. That's what we think. It's all stress, mental stress. And that's what we've been taught. But new research shows that sleep bruxism is 95% airway and 5% biopsychosocial because the airway stress is not getting treated. If you don't sleep well, you go crazy. And this is what the flow chart looks like. There's going to be oxygen desaturation because the tongue is going back and creating an oxygen stress, which then awakens the aortic bodies. And then there is going to be a neuromuscular accommodation to maintain the airway. So the bone will reposition, but the malocclusion will prevent optimum repositioning, leading to bruxism. This is what a report would look like. You would see a parameter called AHI. It is known as apnea-hypopnea index. It needs to be below 5. But for me, the more important is the number of desaturations. In the blue box, you can see down on the right side. Every desaturation would lead to a brux because the patient has to be kept alive. So if there are 89 desaturations, there are 89 bruxing events. A mouth guard is not going to help with that. Now, I'm a boy. I like my toys. So the more the equipment, the better I can treat my patient. So I have something known as a GEM Pro. What do? I measure each bruxing event as to how much muscle force it elicits. Because if the muscle, so a muscle at rest is going to be below 2 microvolts. A muscle during clench, like a daytime or a mental stress clench or chewing patterns, will be about 250 to 300 microvolts. A muscle at 1,000 or 10, 20 times more than the daytime clenching is because of airway. So unless you know the difference, you don't know whether the clench is psychosocial or airway. So the more the equipment, the better. So you can see this patient has clenched almost 100 times during his sleep at 1,138 microvolts, which can even fracture the bone. So just some practical information. If you see tori or buccal exostosis, instead of sending them to a surgeon to excise them off, give them a sleep appliance first. Because the tori is the body's response to make sure that the mandible doesn't fracture at such high forces and the bone is getting deposited. So stop sending them to the surgeon for excision. Send them after the sleep apnea and the sleep bruxism is controlled. So these are all the things that we look for. We do muscle palpations. We teach all of this at our courses. There's a lot of practical sessions during the course. We look at posture because with every change in jaw, there's a change in cervical posture and vice versa. So we need to be very careful with our diagnosis. Even a single high point. So when a patient comes to you and, you for a filling, simple as a filling, and you check the bite, and they say there's a high point, and you tell the patient, you do whatever grinding you can with 20 micron, 40 micron, but not at 5 microns, right? And then when the patient still says there is some problem in the bite, what do you tell? Adjust. The adaptation. Yeah, the TNJ will adapt at the expense of all of these things. So if there's a high point, the jaw is going to shift. When the jaw shifts, the head is going to tilt. Shoulder droops, arms overturn, the hips rotate, the feet pronate. Patient starts getting back pain, neck pain, leg aches, leg cramps. They go to the physiotherapist lifelong because the dentist is still unaware of the jaw position change. So what I do is I divide neuromuscular dentistry into first phase and second phase. So my job, if the patient is coming after surgery or after any treatment, for example, is to first reprogram the muscles. So when we were taught to provide deprogramming splints, we fail to think what a deprogramming splint does. It only deprograms. It's temporary. Why? Because we were not sure about the job position. Why? Because we are not measuring the muscle. But now there is equipment. You can measure the muscle. Once you find the muscles to be in the precise position that you want to be, you give them a reprogramming splint. Orthotic is what I call it. It's anatomic, just like teeth. And then they wear that for like 2 or 3 months. And then I finish them on that bite with smile designing or orthodontics or surgery or expansion or what, no matter what, because the muscles are now stable, bilaterally symmetric on both sides. This is what every dentist has to do. So how do we get them into that reprogramming splint? I apply a TENS, a very specific TENS. I do axiography to make sure that the condylar trajectories are perfect with the rotation and the translation. I provide them an orthotic and on that jaw position, and I do digital microocclusion on the orthotic. So the TENS that I use is known as a Pro TENS. It's a very specific TENS unit. It's different from other TENS units because if you go to a physiotherapist for pain and they apply the TENS on you, it would be just on a single muscle, so that only that muscle would be, relaxed. On the other hand, with these TENS units, if it's only to one side muscle, only that muscle will twitch. No, that's not enough. We need all the muscles on both sides to become symmetric, just like each other, symmetric, basically. For that, it has to be ultra low frequency, about 1 to 2 hertz. Even 0.67 hertz is the new mantra. It has to be anti-dromic, which means it goes to the nerve and not to the muscle. And then through the efferent and afferent fibers, supplies all the muscles given by that nerve. Bilaterally simultaneous on both sides together, because most of the TENS units come with 2 leads, right and left. To complete the circuit, it has to go to one side and then to the other. There is always going to be a delay, maybe a couple of milliseconds, but that's enough because then the twitching is not going to be symmetric. It has to be at exactly 1.5 seconds apart, each pulse. Only all of these in one same unit can help the muscles of the face achieve an isotonic, symmetric jaw position. So there are only 2 equipments in the world, 2 TENS units in the world that provide with these. One is the Mytronics J5, and the other one is the SDA Matrix Pro TENS. This is what a patient looks like. We teach all of this. So once we have the jaw position, we measure the muscles, we see if they're all fine, and then into the software, we import the CBCT, we import the intraoral scans, we import the face photogrammetry. So they once you buy the equipment, they give you an app with which you can take photos on your phone, and it'll create the 3D photogrammetry, and then you align everything. And once you align, we can then appreciate the jaw trajectories during the TENS. That jaw trajectory is what you can see, the TENS jaw trajectory there. And that is where the jaw wants to be. And that position is then exported as an STL file straight to the lab. You don't even have to register the bite. You don't have to use a occlusal registration material or putty or anything. You can select whichever articulator you're convenient with or your lab is convenient with, and you just send that to the lab. The lab would then design using CAD/CAM or whatever software that they're using, whatever you want. It's that. This is what is known as digital dentistry. And we do this for all our patients. The software also comes with a 3-dimensional digital articulator. So you can move the condyle within permissible limits. You can see on the right side, the figures changing. It has to be in the green. And that jaw position using AI will let you know what the trajectory will be post repositioning. This is especially useful for post-surgical patients. Very, very useful tool. Because if you don't know where you want to place the condyle during the replacement, you have this tool to decide where you want it to be. And we fabricate, we design the orthotic, we gave the patient the orthotic. We even designed the sleep appliance on a neuromuscular bite, not on a 70% maximum protrusion bite, on a neuromuscular bite, and we 3D print it. Now, most of the 3D printing that I do is using the Accurata, because our orthotics, we ask the patient, because it's a reprogramming orthotic, the patient has to use it while eating as well. There's a misconception that you have to remove it while eating. No, then the whole, muscle goes into what do you call craziness. So this is the only system that I know, and there's Print Tray too with their very expensive system. They come with the nitrogen chamber so that all the oxides are removed during curing, so it gives them more strength. I use Accurata. Patient wears this for 3 months. We make sure that patient is sent to the tongue tie specialist, an orthopedic or a physiotherapist, do some myofunctional therapy, sent to the ENT for clearing all the upper airway issues, and then we do bite corrections every 2 weeks, digital bite corrections. So let's talk about that. There are two equipments, T-scan and occlusants. They are both almost the same. There are advantages for both, pros and cons. I generally stick to occlusants because it's very easy on the pocket, and it gives me enough information to help the patient get treated at 5 micron sensitivity. So you can see on the right, you can see that scale going up and down. That is the sensitivity scale. And you can see the pressure skyscrapers coming on the screen. The advantage with the occlusants is the sensor is colored, so you don't have to put an articulating paper again. When you put the sensor in the mouth, it shows both on the screen and on the teeth. That's the advantage. We can check for disclusion time. What is disclusion time? When any human being discludes on canine, it should take less than 0.5 seconds with no interference anywhere else. So we got to keep searching. So if you use just articulating paper, it's literally impossible to be sure. If you use equipment, you're more precise. We do a lot of myofunctional therapy, frenuloplasty if there's a tongue tie, laser therapy, photobiomodulation to relax the muscles a little more for those really tight patients. Because most of the patients that undergo surgery for malignancy, their muscles are all over the place because they don't have any attachments. If there is a missing, if you've done a hemimandibulectomy, there's no mandible on one side, and you want to replace it with a rib, a costal bone or something, a costal rib, and you don't know where to position it. If you do a pre-surgical CBCT and use the 3D articulator, you can find out what the jaw position is, give the orthotic on that jaw position, and then correct it on that position. Now, those patients would also need extra support with relaxing the muscles because the TENS might not be enough. So for them, the laser is very helpful. I do a lot of Roccabado, cervical distraction. I keep training myself almost every time. Like right now, I'm in Brazil learning lactation and breastfeeding because that's important when the baby, as soon as the baby is born, they don't if they don't suckle the breast well enough, then their whole growth is affected. For example, if the jaw is shifted to one side, you can just do some chewing exercises by placing your, for young mothers out there, by placing your forefinger on the edentulous opposite side, which would then, guide the jaw to the other side. It's simple exercises. Even within the womb, if there are any pregnant mothers out there, even within the womb, if the tongue is outside, you can see that. in the ultrasound, or if there is open mouth, you can see that, and you can be prepared as soon as the baby is born with what you need to do. Science is just going really, really beautiful. It's crazy. I just love it because everything is measured and it just makes sense. Now, once we get the muscles to be stabilized, we now have to maintain the teeth, move the teeth to maintain that new jaw position. And this is when we become the dentist. We can use orthodontics by cutting out the orthotic and supraerupting so that the jaw position is maintained, followed by expansion. We can do crowns with smile. This patient, this is one of my first patients ever. This is in 2004 or 5 or something, 20 years ago. This patient came to me with 20 years of headaches and migraines, and that's how she left. Very happy, beautiful. Everyone does a lot of expansion nowadays. Marpe and MSc. I still have faith in the physiological appliances. The ALF I use for kids, the Vivos for adults. Orthotropics, I'm getting into it a little more, but because there's not a good lab in India, I don't promote it as much. We do a lot of dome, which is we with the ENT in tow, we take care of the nasal airway blockages, the adenoids, the septal deviations, the turbinates, inflamed turbinates, and then we place the MSc appliance or the MARPE appliance. The challenge with MARPE and MSc is everyone is orthodontists are doing MARPEs left, right, and center without considering what's happening there. People think when you are expanding, the palatal shells just move to the side. No, they rotate. When they rotate in the orbital axis, there's going to be pressure in the sphenoid bone. That would lead to headaches, intraocular headaches, even sleep issues. Why? Because the sella turcica, which is on the sphenoid, gets compressed, which contains the pituitary gland. So there's not enough growth hormone. There's not enough thyroid hormones. It's all getting squished, and the whole sleep cycle is getting affected. People are not thinking, which is why when you're doing a MARPE, it has to be within the neuromuscular limits. All of this, I apply just an added point, apply into the field of sports dentistry, because if the jaw becomes right, then the head becomes right, the posture improves, and the athlete can perform much better. Not in the current team, but the previous team, half the cricket team had our appliances. I've been outside India so long, so I think I have to get back into the field now. So it's all about teamwork. Everyone has to work together. I alone, as a neuromuscular dentist, cannot function successfully. Finally, we are not just tooth doctors. We are oral physicians, especially from a surgical standpoint. Post-surgery, maintaining the jaw and the bite has to be of equal importance as removing the malignant tissue. Thank you very much. I try to cram in how much ever I can. If you have any questions, please ask.
Thank you so much for such a wonderful session, sir.
Thank you. My pleasure.
Anybody from the participants, if they have any doubt, please feel free to ask, sir, or put it in the chat
If
box.
you can ask me on my Insta post as well. It's a handle as well. So it's okay. Thank you very much.
Thank you, sir. Okay, let's start with the next presentation. I would like to introduce Dr. Emeka Benjamin Okeke. He's a physician, public health researcher, and digital health innovation scholar. He holds an MBBS from the University of Ibadan, Nigeria, an MBA in International Healthcare Management from SRH University, Berlin, and a PhD in Health Psychology and Social Care from University of Derby, UK. His work focuses on integrating digital health technologies with public health strategies to improve access, early detection, and prevention of chronic diseases, including oral cancer. He has contributed to research on global burden of oral cancer, public health education, and participatory approaches for awareness and prevention in undeserved population. Dr. Okeke has also studied on digital health adoption and teleconsultation in research limited settings, exploring how technology enabled interventions can strengthen equitable healthcare delivery. He is currently serving as Director of Partnership and Engagement and Acting Director of the Center for Digital Healthcare Health Research, Innovation and Practice at Cephas Health Research Initiative. At ICON 2026, Dr. Okeke will present on digital health and public health strategies for improving oral cancer awareness, early detection, and prevention. Sir, please start with your presentation.
Okay, can you hear me? Thank you so much, Rich Sudha. Is that the right pronunciation?
Yes, sir. I'm Dr. Radhika. Thank you so much,
Okay,
sir.
Dr. Radhika. Okay, thank you so much for the right pronunciation. Okay, I'm a Nigerian physician.
Sir, your voice is not audible. No, sir, I cannot hear you. So I think so there is some issue with the microphone. Am I audible? Okay, sir, but your voice is not audible. There is some technical glitch. Sir will be joining us very soon. I request all the speakers to kindly put their mail IDs in the chat box so that if anybody has further issues or they want to communicate further, they can have an access. Anything, either a mail ID or LinkedIn profile ID or any Instagram page, anything is acceptable.
There is some technical thing happened. Dr. Benjamin drops out, and I think he is trying to reconnect. So just wait for a while. As soon as he connects, he will start his presentation. Thank you.
Can you hear me now?
Yes, it's audible, sir.
Oh, okay. Yes, I know. Okay, I'll share my screen now.
Yes, sir.
Okay. Good afternoon, everybody. I'm connecting from UK. I want to thank the organizers of IOCCON 2026 for the opportunity to share this work. And today I'll be discussing on digital health and public health strategy and how it can work to provide, how this can work together to provide and improve oral cancer outcome in low and middle income countries. My focus will not just only be on technology, but it is going to be on how digital innovation can meaningfully be integrated into existing public health system. My goal here is to everybody knows what oral cancer is, and well, what oral cancer is one major type of cancer that remains one of the most preventable or yet deadly cancer in the low medium income countries. And the tragedy is very notable, as it is not just the incidence but the late stage detection, which is common in these countries. Now, in many settings, early detection systems are weak. Their awareness is limited. Apart from that, we have specialist access is very scarce, especially in countries where we have little oral pathologists, oral specialists available. This creates a cycle of late diagnosis and poor survival outcome. And um, where there is a digital health innovation, if properly embedded within public health strategy, can close this critical gap. And to understand why digital tools matters most, we must first understand the scale of this burden. Over 70% of oral cancer deaths occur in low, medium income countries, and this burden is not evenly distributed. In South Asia, Sub-Saharan Africa, and also some part of Latin America, they carry a big chunk of this mortality. The issue is not only about the biology, it is health system capacity, their awareness, and their access. And when we examine the risk factor, we'll see the pattern and how deeply this is rooted in the social and economic conditions. We have some of these risk factors, and there are common things that we see in our day-to-day lives style, especially in how we make use of things that we use in our environment. We know tobacco and alcohol are major contributors, and this is something that is a major key risk factors. But in many low, medium income countries, additional factors such as the chewing of betel nuts, human papillomavirus exposure exposes this increases this risk. Um, I want to also emphasize that poor oral hygiene, low awareness, and limited screening further delay detection. This is very important to note that oral cancer is not only a clinical issue, it is a public health system issue. And we want to see what exactly is failing at the system level. Many low, medium income countries face shortage of oral health specialists and oncologists. We have weak referral systems. Pathology services are limited. Apart from that, we've noticed that cancer registries in these countries, in low, medium income countries, are incomplete, even with the fact that patients, even when they present early, the system may not be able to respond effectively there because of the financial and geographical barriers to treatment. This is where digital health becomes more important, and where innovations like the use of digital tools could be a strengthening tools. What is digital health? Everybody knows what digital health is, but I would define it as the use of mobile technology, telemedicine, artificial intelligence, and electronic systems to improve service delivery, majorly healthcare service delivery. Then it helps bridge, the emphasis here is to bridge, do you understand? And what digital health does is to bridge geographical and specialist gap. It reduces costs barrier, especially in helping to provide healthcare services, oral health services from whoever it is that is providing it to the end users. It provides information flow. Now we're going to examine how this works practically in oral cancer management. Teleconsultation connects primarily healthcare providers with oral health specialists in real time. Now, what this does is that it reduces the referral delay, lowers traveling cost, build local diagnostic capacity. Apart from that, you could say that in resource limited settings, virtual mentorship can also be transformed. Beyond specialist consultation, we've noticed that digital tools can also empower communities directly. In low medium income countries, the use of mobile phones is a widespread thing whereby everyone is making use of has a phone and has accessibility to a mobile phone. And in this way, we've seen that mobile phones are widespread and even in low income settings. Now, the SMS, short media messages, campaigns and mobile apps can improve awareness, promote tobacco cessation, and also send screening reminders to people. In this way, oral health pathologies, cancers could easily be detected, and also screening can also be done if if technology can be introduced into the setting. Community health workers can use digital tools to assess risk and refer patients earlier. And as technology evolves, artificial intelligence is beginning to play a very big role. The artificial intelligence has been able to can analyze oral images and assist non-specialists in identifying suspicious lesion. However, we've noticed that the AI itself must be validated locally. Now, we've noticed in some research that have been done by Albert et al. In 2025 that local data set is very important in the validation of AI used locally. This is very important as we've noticed that misclassification risk could increase if we don't have data sets available. Technology must therefore be complemented and not replaced. Clinical judgments should only be based with the use by when data sets are available. Technology tools are not just essential and beyond diagnosis. It's very important in surveillance and also in data system. Without data, there is no strategy. Therefore, we've noticed that electronic cancer registries allows government to track incidents, screening rates, and also their outcomes. Data integration supports better resource allocation, and therefore we've noticed that national plannings are very important, especially in the terms of having this linked to government servers precisely. So digital tools alone are not just sufficient enough. We've noticed that the integration into broader public health strategy is very critical. In this slide, we're going to be talking about how integrating digital tools into public health strategy, which is the core message of my presentation. I've noticed that digital health should be aligned with national oral health strategies, non-communicable disease framework, and also tobacco control policies, which are readily available in most countries. These policies are available in most countries. We have HPV vaccination programs available in most countries. All these policies can as well be integrated and must align with the use of digital tools, the digital health tools that are to be provided if if the effectiveness of the use of digital tools could be factored in. Now, the emphasis here is not just about the using digital tools or introducing digital health in combating oral cancer. the emphasis here is to ensure that technology is integrated into the policy that is available, and this can only succeed if if integration is not properly done. Now, however, implementation requires careful planning. The infrastructural gaps, connectivity issues, and data literacy barriers must be addressed. These are major implementation consideration. And apart from that, privacy and data protection are something that is non-negotiable, especially in digital health. Now, how does this affect the implementation strategies? We've noticed that communities' engagement are very important, especially to ensure sustainability and trust, especially in the use of these digital tools to provide healthcare services. So, based on this evidence, and with several key recommendations would be formed, would be emerged, so that we would understand how digital health is important in oral health, oral cancer screening. Now, the recommendation will start with well-designed pilots embedded within the existing health system. We need to train and empower community healthcare workers, build interoperable and ethnical database, which is very important in ensuring that this because you won't have your details exposed or given to another set of person that does not does not need or does not have access to this. Apart from that, we need to secure long-term fundings and policy commitment. You can't just start up the use of digital tools in providing oral care and then stop at it when equipments have been brought for its purpose. Apart from that, the goal is not just to digitalization, but for its own sake, is to improve early detection and survival. So at the end of the day, it's not just about making sure that we use digital, we provide oral cancer screening and prevention and via digital means, but to ensure that this is sustained and also there is a long-term funding for this. In conclusion, I want to say that oral cancer in low medium income countries is both preventable and detectable at early stage. Digital health offers practical solutions not only to close this gap in awareness, but also in its diagnosis and surveillance. However, the impact of this depends on collaboration, capacity building, and integration into the national strategies. And if we can combine technology with strong public health foundation, we can significantly reduce the burden of oral cancer globally. Thank you for listening. If you have any question, please, you can ask me. Thank you.
Thank you so much, sir.
Thank you, Dr. Radka.
It was such a useful presentation. Thank you so much, sir. Anybody has any doubts? They can put it in the chat box or just connect with sir. So you can leave your mail ID in the chat box so that later anybody can connect with you.
Okay, thank you so much. Yeah. Have a nice day.
Thank you so much, sir. Now I could like to conclude day 2. And As we conclude day 2 of this remarkable conference, I extend my sincere gratitude to our distinguished international speakers for sharing their expertise and inspiring us with their insights. A heartfelt thanks to the organizing committee for creating this wonderful platform and giving us the opportunity to learn from just such eminent voices. With today's success, we look forward to gathering again tomorrow for another enriching day of discussions and discoveries. Thank you all.
Thanks, Dr. Radhika, for staying with us for a long and doing, say, chairing the all sessions. And we would be having more energetic and, more mesmerizing sessions tomorrow. We have, say, 12 speakers tomorrow, and then 13 speakers day after tomorrow. So the day 1 and day 2 are most, we are talking about the public health. We are talking much about diagnosis and all. Now, on the day 3rd and 4th, we would be talking more about the advanced cases management, whether it is surgically or medically, and then the rehabilitation and the facial processes, etc. So the next 2 days again, the 2 days were for diagnosis and incidents and the prevention and all. The next 2 days will be how to the manage the advanced cases, how to diagnose, and there are multiple modalities to manage oral cancer, whether it is through radiation, whether it is through medical, through medical oncologist, through chemotherapy, or through surgical oncologist, or through a joint regimen. So day tomorrow and day after tomorrow we'll start early, say at 10 in the morning. Maybe tomorrow, Dr. J.K. Singh, who is not able to join day 1, he would be joining. He is a renowned oncologist from Patna. And then our sessions will start. So we'll join tomorrow at 10, and day after tomorrow again 10, and we'll go till say late evening tomorrow. So we'll be expecting more engaging participations of all our audience as well as all speakers and all. Thanks, Dr. Radhika, for chairing our sessions for day 1 and day 2. Thanks a lot. Thanks a lot from all organizing committee on behalf of all the technical team, etc. We'll connect again. We'll tune again tomorrow at 10 in the morning. Thank you.
Yes, sir. Thank you so much. The pleasure is mine.